So here's safe and effective care, management of care. Here is safety and infection control, which falls under the safe and effective care category. Here is physiological reduction. We haven't done any of those. Today, we are doing psychosocial integrity. We've done health promotion and maintenance and stuff, but this is where we're going to be throughout the next 4 hours, right? So we're going to talk about chemical and other dependence, especially alcohol abuse. We're going to talk about that. We're going to talk about mental health concept, mental health diseases like bipolar, depression, schizophrenia. We're going to talk about use and neglect. Therapeutic communication is really where your test-taking strategies will come from. So we're going to zone in on that. We're going to talk about grieving. We're going to talk about DABDA, right? The little mnemonic for the grieving process. We're going to talk about a few health screening, and we're going to practice lots of questions. By the time I'm done, psychosocial integrity, psychosocial nurse, psychiatric nursing, and mental health, whatever you want to call it, every school calls it something different, you'll be fine with that, okay? So that is what we're covering today. Okay, so psychiatric nursing, mental health disorders. All right, so part of this, there's something we call cognitive behavior theory. As you can see here, there are some theorists on your NCLEX. There truly are. And those are the information that you've forgotten about when you took mental health. It's just the way it is. It's the nature of the beast. It's not like you'll remember, a little bit about schizophrenia, bipolar, manic episode, but you're going to forget about the theorists because most students do, and that's okay. It's my job to bring these things back that are important, that are necessary, especially Madame Pablo, who's considered to be the mother of psychiatric nursing. We're going to talk about her. She plays a very important role in psychiatric nursing, and there are NCLEX questions about her and her theory and the milieu therapy, which she came up with. So we will talk about her. She's important. Behavior theory is another important concept. So behavior theory talks about the symptoms of mental illness that are the result of learned behavior. So some theorists tells you that, you learned that behavior, not that you were born with it or any type of neurological, chemical imbalance they claim, that's their theory. So be familiar with those. So cognitive behavior focuses on the premise that a person's thoughts control their behavior. Okay, so, and then here's another thing I want to remind you. So throughout the review, I'm going to teach you some test-taking skills and strategies, and I'm going to bring Maslow into play because Maslow is big when it comes to psychiatric nursing. But the other thing I want to remind you of is, especially those of you who have experience in the mental health field, this is definitely an area where things are not being done by the book, and your test is by the book. I don't want to say whether that's fortunate or unfortunate, that's a matter of opinion, but your exam is based by the book. And this is in an area where a lot of what's being done is not being done by the book. So if you work in a mental health facility, I would suggest you definitely make sure that what you believe, what you've seen is by the book. When you sit to answer these questions, you need to go by the book. And I teach by the book. I know, like, I've been in these settings from different perspectives as a floating nurse, as a student, as a visitor visiting someone. So I know, and see what's being done by the book and what's not. So we've got to go by the book. Okay, so with that being said, and also your opinion, you need to keep your opinion, your experience, and all that stuff out of this. Okay, you've got to go by the book. Okay, so now cognitive behavior theory focuses on the premise that a person's thought controls their behavior. I personally believe there's some truth to that. Okay, especially as a Christian with my religious beliefs, I do believe that so much starts with our mind, with our thinking. So you need to guide that and direct that. But that's a personal thing. But there is a theory out there in reference to that. And then behavior we just talked about, and Madame Peplo, we're going to dive into her theory later on. So she fits here under this umbrella a couple different times because, again, she's given the title of Mother of Psychiatric Nursing. So you see how important she is to the topic that we're discussing. She wrote this book called Interpersonal Relations in Nursing, which, you know, became very popular. A lot of schools use it, okay? And it talks about the nurse-client relationship, okay? There's questions about the nurse-client relationship. The only, and let me take a moment to teach you about the word only. It is an absolute, okay? Only, all, always, forever, every, those words are all absolutes, okay? They're so, you know, definite. So she says, well, you know, in general, the book says the only relationship you have with your client is a therapeutic one, okay? And the client needs to receive unconditional acceptance, okay? The relationship between nurse and client is client-centered. It's not about you, the nurse. If you ever picking an answer that puts you, the nurse, at the center, it is not correct, because this test is not about you, it's about the client. So we are client-centered. The relationship is developed according to the client's perceived readiness. That is so important. Nothing's going to get better until that other person is ready for it. So there's so much that begins there. We're going to talk about the patient-client relationship, but you do need to know about Madame Peplo, Hildegard Peplo. She is the mother of psychiatric nursing, okay? We also will talk about biochemical effects, because a lot of the disorders are based on an imbalance and biochemical, like dopamine, GABA, epinephrine, norepinephrine. We're going to talk about those biochemicals, because they play a major role. So there's a lot of research on biochemicals, okay? So there are a number of neurotransmitters, but we only need to focus on a few for mental health. One of the most important ones is serotonin and dopamine, norepi, and GABA. Okay, right here, the major ones we need to focus on. So some of the diagnostic tests that's also used, in addition to looking at the neurotransmitters, will be a PET scan. Okay, that's the bottom left. This one is a CT scan right in the middle, and of course MRIs, okay? Those three tests are used to study the brain, okay? Because we're talking neurological problems. So those are some of the diagnostic tests where, as we go through diseases, you're gonna hear me say, okay, so we would do a CT scan for this, an MRI, a PET scan, okay? All right, so now we're getting into some meaty stuff, not really the real meat stuff yet, but there are questions on your test about defense mechanisms. Okay, so everybody has, to some limit, a different level of defense mechanisms that they use, okay? There are several, and I don't know which ones you're gonna be questioned on in the end class. My job is really to go over the most popular, prominent ones with you, but you are to take a look at each and every one of them and make sure you get a clear understanding of what they mean, because these questions don't pose these questions directly. They give you scenarios, and based on the scenario, you need to be able to tell what defense mechanism the client is using. But let's start from the beginning. Why do people use defense mechanisms? Okay, people use defense mechanisms to relieve anxiety, and everybody does it at one point in time or another, okay? Let me make sure that's not one of you, no. Okay, so use of defense mechanisms is usually unconscious, or sometimes some folks, know they're using it, some don't. But let's start with the little ones. You'll hear this again, or you've heard this already when we did growth and development. Some children will use, some specific defense mechanism, like denial. Regression is a big one. We're gonna go over regression. projection. So we're gonna go over all of them, but please, not only children use defense mechanisms, okay? So I've looked for different charts. Some charts I've even made up because what I wanted to do or try to do is organize this information for you. So I did find a few different charts to better organize this for you, because some of these defense mechanisms fall under different umbrellas. So some fall under the narcissistic, type of behavior or disorder. Some fall under immature, some fall under anxiety, and some mature, okay? So narcissistic ones are the projection, the denial, and the splitting. And look at these examples. Projection is when a client takes their negative feelings and unacceptable behavior and make it seem like somebody else has that. They take that attribute, that thought, and put it on someone else. I don't like a boy named Mike and say, I know that dude hates me, I know it. Okay, you see how it's internally, the student has a crush on the teacher. They say the teacher's coming onto them. You see how it's the student having the issue, but they make it seem like somebody else is having the issue. The woman sees another woman and she's jealous of her and she says that woman is a gold digger. Okay, you see what I'm saying? Does everybody get that one? That's projection. Projection is when you throw it at somebody else, okay? Now, sometimes what I see is that students will miss or mix projection with introjection. So introjection is definitely an unconscious imitation. The resident acts and dresses like the attending he admires the most. So introjection is when the client is experiencing or showing the behavior, okay? Let me give you another better example of that. I'm gonna come back, don't worry. So introjection, a husband's symptoms mimic his wife before she died. Do you see how he's the one having the issue? Okay. So whenever they make somebody else seems like they're having the problem, that's projection, and narcissists tend to do that. Whereas when it's themselves experiencing it, that's introjection, and that's more of an immature behavior. Okay. Denial, I think you're good with. I don't need to go over denial. Splitting is a little bit different. Splitting is like, black and white. No gray area. You're either in or out, yes or no. There's no maybe with these folks. Okay. Like you see the example, the nurses from the day shift are great, whereas the night nurses suck. It's like there's no, like they decide, like that's it. So that's splitting, and it kind of, like, if you think of splitting, right, kind of makes sense. So narcissistics are not too bad as far as the three that they have for you: projection, denial, splitting. Okay, the immature one. So they have behavior of blocking, where they temporarily, I don't remember. I don't know. I don't remember. Like, they don't seem to remember stuff that they should have. Okay, regression is special. There are NCLEX questions on regression for sure. So regression is when somebody goes back a developmental stage, okay? There's so many examples I could give you of this one. You have a toddler and then you have a newborn baby. The toddler may regress. Let's say that toddler knew how to brush their teeth, wash their face, put on their clothes. And all of a sudden, because of the birth of the new baby causes some stress, attention taken away from them, they regress. They had stopped sucking their thumb, they go back to sucking their thumb. They had put away the special blanket or teddy bear, they go back to the special blanket or teddy bear. Okay? So they didn't, used to wet the bed, they're wetting the bed. So stuff like that. So they regress a developmental stage. And this happens frequently with children when they're hospitalized, when you move, when somebody passes away. So any little thing that stresses them could cause them to regress. Okay, next one. somatization. That's when the person is having a mental psychiatric disorder, but then they're showing physical, okay, sign and symptoms. So the husband, the wife sees the husband with another woman, all of a sudden she's having visual problems. You see what I'm saying? So the problem is mental, psychiatrically, but there's some physical sign. You see another example here. I had a terrible headache during the exam. So although it's probably, emotional, psychological with the exam, but there's some physical symptoms. Okay, that's somatization. We did introjection, so blocking, regression, somatization, introjection are all immature. They fall under that umbrella. Okay, there are quite a few under the anxiety umbrella, and there are a few that are really extremely important. And I say this because I know for sure students have come back after the exam and say, I had this, this, and this. All right, so displacement is a very popular one, okay? We'll practice some questions on displacement so you can see how they phrase them, okay? So displacement is when you're really upset at one individual, but you take it out on another that's more acceptable, okay? You shift it, you displace it, you don't put it where it actually belongs. Okay, my dad was angry with my mother and started yelling at my baby sister, right? Your boss reprimands you, you come home and you kick the dog, right? That one is a real and correct question, y'all, okay? Your boss reprimands you, or the head nurse reprimands you and you yell at the patient, right? So you're displacing that anger. So they give you a scenario, okay? Repression right here. Bad idea or feeling eliminated from consciousness. Forget and forget. The child was abused by his father, but he doesn't recall any of that. So repression is when somebody, like they choose not to ever remember that bad experience. The word just really tells you repress. That's really what they're doing. So it did happen, but they just, forget and forget. So that kind of says it all. I want to pull a couple of them here. Rationalization you can do. That's just making excuses. Let's do intellectualization and dissociation. Those two are important. And I think you already know passive aggressive. So because those are so common in real life. Okay, let's pull out intellectualization. That one is important. Isolation of effect, not as much. All right, intellectualization. Use of intellectual process to avoid effective expression. All of the methods used to get to this diagnosed end-stage cancer are really interesting. So this is where the client becomes very knowledgeable about the disease, about the disorder. Okay, they use that intellect to avoid the emotional part. Okay, does that make sense? Okay, you'll see some examples in a moment. So the other one I want to pull out under anxiety, there's so many, is dissociation. Separates from one experience, like out-of-body experience. When a woman was being raped, she felt like she was watching it from above. So they kind of take themselves out of their body in a way. Okay, I know that sounds a little like, so they have like this separation from self, hence the word dissociation. They could even talk about it as if it was somebody else. Okay. So yeah, that's that one. That one is very unique. But do you see how if you don't zone in and know the actual definition, how some of them are close, where, it's one word or two words that really tells you, oh, it's this one. So you have to go over this again. The only time you do it can't be when you and I are doing it together, okay? Mature. So mature is with humor, sublimation, and suppression. Suppression is different from repression, okay? So you see here, we covered repression right here. Let me use my cursor right here. This is the forget and forget one, right? Like, with suppression, so conscious forgetting, the only conscious mechanism, forget and remember. I'd rather forget that my dog was run over by a dog. So this is consciously done, okay? Where forget and remember, like they know it happened, they choose not to address it, deal with it, acknowledge it, right? So that there's a big difference, okay? So don't mix those two. One more time, recap, repeat. Don't mix repression, okay, with suppression, okay? Very different. Sublimation, unacceptable impulse into acceptable channel. This one's on your NCLEX as well. And this one is not a bad one. It's like somebody who hates teaching and then they're an amazing teacher. Somebody who hates children, but they're the greatest babysitter. Somebody who hates their boss, but they're the best secretary, right? Like that's the one. That's sublimation. Okay. Pyromatic starts working in a special effect company in Hollywood where he can blow things up. They're very, very good at it, but deep down inside, they absolutely 100% abhor that, right? So it's a little weird, this one. So they have these unacceptable impulses that are channeled into acceptable channels. So it is what it is. Humor you get. All right. So I have a couple of different charts for you. Again, the one you're pulling online may not have all of these updates. I will update this one. Like I was working on this up until late last. I have an obsession with these PowerPoints. I need to leave them alone. But I think these are great also because they give you some other examples in addition to the ones I've verbally given you. So displacement, very important one, regression, repression. So those are great. Like I like these little charts. When I found them, I was like, okay, this is awesome. This is a link that talks about the defense mechanism. Those of you, you know, if you're a visual learner, you can take a look and watch this little video about them. So this is another chart that goes over the description again and some examples. Okay, so there's quite a few here that I have for you. So let's practice a couple of questions so I can see if you get it. Okay, and I want to see some answers. I hope everybody's, you know, awake, alert, oriented. I don't know what time it is where you are, but get coffee if you're a coffee person, tea, something with caffeine to wake you up, right? All right, so when the nurse informs an adolescent client that a scheduled parental visit will not occur, the client throws a cup at the nurse. In order to best respond to this behavior, the nurse should conclude that the client is displacing which of the following. So we have an adolescent who's upset and throws a cup at the nurse. So they're pretty much asking you, what defense mechanism is this? Reaction formation, displacement, projection, or denial? Throw me some answers, please. I don't see any answers yet. Let me refresh. Oh, there we go. Okay, I was on the bottom. I was on the bottom of the thing instead of the top. Yeah, the anger is not. They're not upset with the nurse. This is displacement. They're really just not, okay? But they're showing that, you know, against the nurse. And we get that a lot, don't we? Because we're at the forefront, okay? We're just at the forefront of the madness. That's all. So this is displacement, okay? We have a couple more. We're going to practice on those. Now, stress. We're going to do stress, and then we're going to go into crises. Those two are important, and they're on the NCLEX. Now, a little test-taking tip. Whenever clients are dealing with stress or crises, especially stress, we need to be little investigators. We need to dive into what they've done in the past to relieve stress. especially the older the person gets, the more they build some mechanisms on how to deal with stuff like that. So sometimes the question is, what have you done in the past? Easy one, right? Okay, so stress is universal and stress is individualized. That means everybody does not experience stress the same way, but everybody experiences stress. It doesn't matter who you are, how wonderful, rich, beautiful, intelligent, whatever else you want to add to that, you're going to experience stress, a degree of it at one point in time or another in your life, right? Nobody can dodge that bullet. I wish. Here's another concept you need to remember. The way folks deal with stress depends on how they perceive the stressor. What you feel is stressful, I may not. And vice versa. What I find to be stressful, you may not. Right? So think about it. If you think something is stressful and I don't, I'm going to react differently, and vice versa. If I think it's stressful and you don't, you got it. So that's an NKJV question. The greater the stressor is perceived, the greater the response, and that makes sense. Okay, so don't get that question wrong. Okay, it depends on how we perceive the stress. Okay, and stress could be internal, external, physical, psychological, emotional, cultural, microbiological. My goodness, we could go on and on. And you see the little picture here. Stress is the #1 killer, right? Some things that stress causes like blows our mind, right? Migraines, diabetes, allergies, asthma, depression, ulcers, especially ulcers. I've known nursing students end up in the hospital with ulcers over this test. So don't allow that, right? So remember the whole theory about it starting with your thinking. So there's some connection there. All right, stress response. We're going to go over the different stages, okay? Because stress could lead to crises if we don't intervene. But our body responds in so many different ways. Our sympathetic nervous system, parasympathetic nervous system, it all kicks in. So one of the #1 ways is with your fight and flight, right? When you the stress stage begins, the alarm reaction, that is stage 1, kicks in, right? And then you go through exhaustion, death, and all of that. But let's stick to stage 1. So your fight and flight response activates. Your sympathetic nervous system kicks in. Your heart rate will go up, okay? Your cardiac output will increase. Your respiratory rate will increase. Your mental alertness. So you see how some stress is good stress, okay? We want you to be alert. It's just too much of it is not good. And being in that state for too long is not good, okay? But we do want your blood vessels opening up a little bit. We do want you to be a little bit more alert, but not to the point where, like, let's say, God forbid, you're taking the test and then your stress level kicks in. We don't want it at the level we're about to go to. We want you a little bit alert. We want you, deep breathing. You may have a little increase in heart rate, but nothing to the point where you don't remember who, what, where, when, right? That's too much, okay? But as the alarm reacts, yeah, your pupils are going to dilate. You're going to release adrenaline, epi and norepinephrine from the adrenal gland on top of your kidneys will be releasing those hormones. Okay, blood flowing through your skeletal muscle, arterial blood pressure, your antidiuretic hormone from the back of the pituitary gets activated. Okay, so does your anterior pituitary, increase water reabsorption, cortisol, protein, fat, catabolism, all of that is happening. Aldosterone gets secreted. Your body reabsorbs sodium and water. That's why you usually don't have to pee. Now, everybody's different. This is a book where that's what happens with the majority of the people. Some people who get stressed and they do urinate. They're not the norm, okay? So there are exceptions to this rule. But generally, your parasympathetic with the feed and breathe, right? Your urinary system and your gastrointestinal system, the kidneys produce less urine. Okay, kidneys secrete more potassium. Okay, so all of that is happening physically, okay, from stress. Now, if you don't fix that and you stay in this mode, yeah, death is at the end of these stages, okay? Now, if we don't fix this again, the client can sometimes go into a crisis. So we're going to go into this. There's different types of crises. There's acute, there's exhaustion, and there's shock. You can imagine like what's happening at the end of that. So at the beginning with acute crisis, the client temporarily loses control. NCLEX. These are not the client you have make decisions. I know we teach autonomy, right? Let the client decide. They're awake, alert, oriented. Don't take away their rights. They have the choice. Yes, all of that is true, but this is the exceptional client. This client can't decide. So this is not the client you give options. This is the client you find out who the next of kin is. The next of kin needs to decide. If they're married, that would be their spouse. If they're not married, but they have a child who's of age or a parent that's still alive, if none of that exists, no spouse, no parent, no child of age, then yeah, the court, physician, somebody else will have to make the decision. They can't, okay? So client is temporarily losing control with reality. Sometimes they don't know who, what, where, when, okay? There's some emotional reaction where you see that overwhelming. Again, the decision-making, problem-solvings are inappropriate and inoperable. Like, don't let them, make them, ask them to decide. Their thinking is scattered, okay? Sometimes they go and lock themselves up somewhere. Some of them just lay there, literally lay there, okay? And then they start to think about suicide. So we're going to talk about that. Exhaustion crisis fall under that emergency condition. Person has lost effective coping. They cannot. How are you going to ask that client to make a decision? Okay, they can't function. So NCLEX tests you on that. When they're in acute exhaustion, shock, they cannot decide. That's the last thing you want to do. Okay, shock. Sudden external change cause release of emotions, overwhelms the client. They again cannot make decisions. Okay. There's something we call general adaptation syndrome, GAS. That's the process where the body confronts stress. Okay. Is the GAS. That's just a terminology you need to put under your belt. Okay. So the process where the body confronts stress is the general adaptation syndrome. You're supposed to adapt, right? You're not supposed to allow this thing to kill you. But stress does kill. Okay, so here's a cycle of what takes place, okay? So there's an external event that threatens you, your fight and flight, sympathetic nervous system kicks in. All of this stuff we went over earlier, your heart rate, your breathing, your respiration, all of that changes, and that's a lot of it is due to the cortisol release. If the threat is removed, okay, acetylcholine is released. All of the adrenaline, noradrenaline, the cortisol, it all goes back down and you go back to normal. Now, if that does not happen, death, okay? All of these systems gets impacted. Your nervous system, your musculoskeletal, your respiration, your cardio. You saw that with all of those signs and symptoms that I just went over, okay? So you cannot stay in that stress mode for long. That's why clients die from stress, okay? Throughout the review in the PowerPoint, you will see a bunch of little mnemonics. When you get a chance, go over them. If they help you, adopt them. If they don't help you, make your own, okay? Sometimes I will share mnemonics with students because I know, that general one is helpful for every student that I've encountered. So I will tell you, yeah, definitely memorize that one. But if you find it better to make up your own, I have some mnemonics. They're based on my children's names. They're based on my hobbies and my preferences. So sometimes you may want to make your own if you don't find one that's already there and working. Okay. So remember earlier I told you, find out what the client has done in the past. You do, we want good habits though, okay? We don't want you to eat every time you get stressed. That's not a good habit. It's just not. but listening to music, going for a walk, exercising, you know, all of that is great. Quiet moment. Yeah. I have a whole list for you, but it's up to the client. Prayer, meditation, maybe some people humor. So find out whatever it is. Okay. And sometimes the answer is just that simple. What have you done in the past, Mrs. Jones, to release your stress? Well, you know, dear, I meditate at times. Okay, well, what do you need to do that? Let's do it. Okay. So, yeah. All right. Crisis intervention. How do we help? What do we do based on the type of crisis that they're experiencing? Where do we come in? What's our role, right? Where do we fit? Okay. So the definition of crisis in general, as we read earlier, is temporary personality disorganization with an acute emotional state. That's like a book, right? But you saw earlier, I like to simplify things. Okay. So there's different types of crises. So acute, again, temporary loss, okay? They're overwhelmed. The most important part of that, this is recapping. We're recapping. I know I sound like a broken record, but this is so it stays in your long-term memory, okay? The most important section you need to remember under the acute is that their thinking is scattered. There's a nice NCLEX question here. So whenever there's situation where the client's thinking is scattered, do not ask them to decide. Okay. Same thing under exhaustion phase. They are not function. They have lost connection, okay, with reality. Okay. So you cannot ask them to decide. Okay. So the other thing you need to remember, these things are individualized. I said that already, so I'm repeating myself. Why do you need to remember that? Because you can't say, Mrs. Jones, get over this in a week. Mr. Jones, get over this in 3 weeks. No, it may take one week. It may take another one 6 months. Okay, it varies. Okay, the average is about 4 to 6 weeks, but everybody's different. Okay, so keep that in mind. Don't put a time on these things. Okay. So now we need to talk about the pharmacological component to this, okay? So yeah, there's a lot of emotional support, group meeting, family support, all of that, yes. But we will and need to talk about anti-anxiolytics, okay? Because these disorders cause anxiety. So now, before I get to that, there's an important concept that I want you to know and remember, and I need to make sure you do understand that too. I don't know if you've ever heard of the word venting. If you've ever heard of that word, let me know. Throw a yes at me, thumbs up, or no. The word venting. Have you heard of that word? Do you know what it means? Venting. Anyone? Okay, perfect. I see some yeses. All right. That is such an important word and concept for this area. And I'm going to cover this in different angles so you could see your questions and how they phrase them, how they, you know, where they come from. Okay. Okay, so from the client standpoint, it is a good thing to vent. You see here how it says allow free discharge of emotions. You want your client talking, yelling, screaming, blaming someone, right? That is venting. You want them talking, sharing, communicating. You want that because that express of emotions help them get better. Okay? So sometimes you'll see where, okay, a couple has lost a child. You know, what's the most therapeutic thing here? They say whatever gets them to vent, to talk to. Yep, that's and anything in that scenario that tells you, yep, they're discussing this. Now let's take this on a different angle. Let me show you how else these questions gets phrased and gets presented to you. So we healthcare provider, I've told you in the past, there's not many questions about us, right? There's just not. But so sometimes we healthcare providers need to vent. If you work in a setting where you're seeing people dying all the time on a regular basis, you too need to vent. So generally, like for your hospice nurses, ER nurses, especially if it's a big hospital, they should have a community, a department, somewhere where these nurses go and vent and talk and release, right? Because can you imagine? Because they may not have the support system at home to go and say, you know, and talk about, especially once you've had a client for a while. You know, when they pass away, it's like family. So they do need to talk and vent. And so that's important. And you need to keep that in mind, okay? It is also our job to continuously, ongoing, reinforce the client of who they are, where they are, and what's happening. Mrs. Jones, you're in the hospital, I'm your nurse, this is what's going on all the time, because a lot of them have disorders where they forget. Who are you, dear? Where am I? What's going on, right? So it's our job. You're Mrs. Jones, you're in the hospital, I'm your nurse, you know, that way you help them calm down. Okay, let me cover the nursing interventions and then I'm gonna go into the pharmacological. So quiet room, do not stress these clients, right? Like, duh, they're kind of already stressed out. So do not stress them. Everybody shush, please be quiet. Turn off the television, no excess stimuli, okay? Find out who the support system is. Look in the chart, who admitted them? Is there a spouse? Is there an uncle, sister, brother, anybody, right? Teach them about deep breathing, the different complementary alternative medicines. All of that stuff is great. Okay, so now let's talk about the anti-anxiolytics. This is the family of drugs that will need to come into play. Primarily your benzodiazepines. Okay, short, you'll hear people say benzos all the time. And I'm going to stick to generic names. I know you're much more familiar with the brand names, but I'm going to purposefully stick to the generic names because those are the ones I need you to memorize and remember. Okay, we will talk about, you know, the rest of these. This is coming up in this session. We'll talk about the antidepressants, the antipsychotics, typicals versus atypicals, but for now we're right here under the anxiolytics. Okay, anti-anxiolytics. Okay, so your benzos, we're talking alprazolam, we're talking clonazepam, we're talking diazepam, and lorazepam. Okay, do you see how we were Pam, 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 right? That makes it easy to remember. And I love this little chart because they're all just so, you know, right on top of each other. They have the brand and the generic, because I know you're familiar with Valium, Xanax, and Ativan and Klonopin, but you do need to deviate to the generic name. Alprazolam, clonazepam, diazepam, lorazepam, zapam. So even if you're doing an NCLEX question and you see that, you're like, ooh, what drug is that? Oh, zapam, right? Not all of them, but a few do, and then zapam. So that's a good habit to build. Your SSRIs are really antidepressants, but these have some anti-anxiolytic effect. So they're under this umbrella as well, okay? Escitalopram, paroxetine, Paxil, you're familiar with that, and sertraline, Zoloft is a great Zoloft commercial. And you know what else I would do if I were you? I like making little words, especially if you're having a hard time remembering these. So for example, whenever I see a vowel, I know I can make a word, right? So I see vowels here. You could make a word with these SSRIs, right? Because I see a vowel, E, step, Okay, pest, whatever, however you want to organize that. There's a vowel here as well. So you could make the word clad. Okay, you see what I'm saying? For you to remember this. So that's how you study, everyone, if you're trying to, because I know some of you have a hard time remembering these drugs. So that's why I show you these little things for you to do, but it is up to you to do it, okay? When we talk about the antidepressants, same thing. You could make little words with the SSRIs, with the MR. Sometimes it's a little difficult when you don't have a vowel. So you could put something in there that's silent to make a word that you'll remember, and by adding a vowel in there. Okay, so that's just a little study tip. But let's get into a couple of these benzos. Benzo is a very special category drug, because what happens is some of these drugs don't have one purpose. They have multiple purposes, okay? So your benzodiazepine, they're used for both mental and physical problems. That's why they have multiple purposes, okay? So sometimes they're being used for anxiety. Sometimes they're being used for anesthetic, seizure, muscle relaxant, alcohol withdrawal, insomnia. You see how they have so many different purposes. These are all benzos, okay? So they, again, you could see like, oh, well, then we study this under anxiety, and then here we are under seizure, talking about the same drug. Yeah, so that does happen. So here we'll talk about Valium as an anti-anxiolytic, or under benzo, but we'll talk about Valium again when we do seizures. We'll talk about Klonopin when we do, because of the family of drugs that they are. That's just the way it is. All right, so benzos work on the receptor neurotransmitter in the brain called GABA. So what GABA does, GABA slows activity in the brain. Okay, that's why it works great. Like these drugs work great with seizure patients. Now it makes sense, right? Here's the problem. So because your benzos work on GABA in the brain to slow activities in the brain, so does alcohol. So NCLEX, and I see why they question you on that. You can never ever mix a benzo with alcohol, because now you have two substances slowing activities in the brain. You could overdose and die. Okay, so that's an important question. That's a high level question that shows you're safe to practice. Okay, because mixing any benzo with alcohol, yeah, it's going to slow your heart rate. It's going to slow your breathing. And at the end of that is coma and death, okay? You don't want to be on any type of benzo and be pregnant. It crosses the placenta, okay? The drug literally passes on to the baby, okay? So the baby end up, you could have a stillbirth, okay? Worst case scenario, okay? And another thing you need to remember about this family of drugs, all of the benzos, we never abruptly stop them, okay? You will have a rebound effect, okay? And they're highly addictive, okay? So keep all of that in mind. Any questions so far? We're gonna hit a new topic. So we're done with stress and crises. We're going to go into grieving now, okay? Completely different topic. I see a no. I don't know if that's from before or now. Can I get into grieving? Everybody's good? Okay. So grieving, just like stress, is universal and it's individual. That's just the way it is. But think about it, it's true. Everybody will grieve. And when we're talking grieving, we're not just talking about from the loss of a person, right? We're also talking about the loss of anything that's near and dear. People grieve over losing a job. You could grieve over losing your home. You could grieve over losing a body part. You could grieve over a ring that your great grandma left you that meant so much to you. Like, you see, I could go on and on and on and on. So anything that's near and dear to the client, they can grieve about it. It's not for us to judge. Okay, so keep that in mind too, because I've seen sometimes where students choose answers where they personalize it. Well, why would she be crying for that? Well, that's not for you to say. So keep these little things in mind. I know I sound funny sometimes, but I stick to NCLEX, okay? So even if I'm sharing a story with you, if it's not gonna help you answer an NCLEX question, I don't bother, okay? So there's always a lesson in my crazy analogies. All right, anticipatory grief. There's different types of grief. So anticipatory, the name tells you anticipatory. So these are the clients who are grieving and the loss has not occurred. Yeah, that happens a lot in hospice, right? Family members, everybody's boo-hooing and the client is still alive. That doesn't make any sense, right? But that's anticipatory grieving, okay? So for example, Mrs. Jones just got diagnosed with breast cancer. You go into the room and she's like bawling, right? What does that mean? Am I gonna lose my breast? Da, 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 da. So you would need to diagnose her with anticipatory grieving in that case because she hasn't lost her breast, but then, you know, like stuff like that. Disenfranchised grief is when somebody cannot openly grieve, okay? So for whatever reason, they can't cry and yell and scream and let the world know they've lost whatever it is, okay? And that could be for a number of reasons. Complicated grief, it tells you those are usually from sudden losses, unexpected losses. And mourning is slightly different. Mourning is very, very, very much culturally based, okay? So when you get questions that are culturally based, you need to, and the ones they'll throw at you are the very most common ones, because can you imagine, we're not expected to know everything about every religion, right? We're just not. We're not expected to know, you know, the little details concerning every religious practice. No, but there are some few things you need to keep in mind that are like across the board, right? So for example, it doesn't matter your religion, I cannot allow you to mutilate a body, right? If you're hurting another person or your ritual causes harm or deformation of some, yeah, those things we don't allow. So it's irrelevant what your religious practice is if that's happening. You're not going to allow that. But we are there for someone. For example, if somebody loses a loved one and whatever their religious practice is, we help them, we take part of it. And you know, some religions, the body, they must get buried within 24 hours and things like that. So yeah, we get involved in all of that, not a problem, but no mutilating the body. Back to mourning. Mourning is culturally based. So keep that in mind. So for example, some cultures, they don't grieve openly, right? There's no emotional crying, tears and outbursts. Like, I remember when I was younger and I asked my mom, I remember saying to my mother, I don't know anybody who's died. I was much younger, obviously. And she said, don't worry, you know, as you get older, you will. And I was thinking, okay, what kind of an insert is that? But she was so right, especially as I became a nurse and I started going to my clients' funerals and stuff like that, because I worked hospice for some time too. So I got the opportunity to go to so many different cultural funerals. I always sit in the back because I really don't know what to expect. But I've been to funerals, you know, where you know, Jewish versus Jamaican versus Haitian versus African American versus, like, I've been to different funerals and they are very different. It is culturally based. The book is bright, okay, and not component. So, for example, like when I go to a Haitian funeral, I know like they express themselves openly, like crying, moving furniture type of thing. And I've been to Jewish funerals where there's barely any tears, that, you know, so very, very culturally based, okay? Those of you who are probably laughing about the Haitian funeral, it's so true. Yeah, like, very, very different. Okay, so nursing intervention in grief. What is your job? What is our job? What do we do? Okay. We're support system. Okay. There's not like a major, because at this point, this is just one of the situations where there's not much you can say. So your job is to listen, but really listen, right? Attentively listen. Okay? Support, be careful what you say, right? In this area, because you don't want to promise, don't say stuff like, that gives them too much hope, like the person could possibly come back, that loss could possibly, be undone. Like, don't do stuff like that. Okay, those answers are always wrong. Because we can't bring nobody back. We can't bring body parts back. We can't bring losses back. Like, we just don't have the power to do that. And we're gonna go into, little test-taking strategies with therapeutic communication that shows you how to answer these questions. So we listen. We let them vent. We already talked about that word. Let them express it, say it, yell it, scream it. We could do a therapeutic touch, hand on a hand, hand on a shoulder. I understand. So, things like that. So you just be careful, don't say, everything's going to be all right. And then somebody else dies, right? No, you don't want to do that. That's false reassurance. All right. We need to go over DABDA. So this theory was created by Elizabeth Kubler-Ross. Okay. So that's who's credited with the 5 stages of grief. And I must read a little bit of the top for you, although I never read to you because I know you can read, but sometimes I'll do that to pull out some important stuff. All right, so the grief cycle is a framework that serves as a guide to assist individuals with dealing with their emotional reaction to change or trauma. We do not always experience all 5 grief cycle stages. So one more time, we do not always experience all 5, okay? Some stages might be revisited and others may not be experienced at all. Transition between stages can be more of an ebb and flow rather than a progression, okay? So keep that in mind. So students always think you have to experience all 5 and it's got to be one next the other. No, it's not like that. Everybody's different, okay? But I'm going to go through all 5 stages and I'm going to show you how somebody grieves positively, okay, or adaptively, normally, exceptionally, whereas somebody could grieve maladaptively or maladaptive response to the loss. Okay, so there's a positive to this and there's a negative. So read your scenario to see what this client is doing. Now, if it's all good stuff, they're venting, they're verbally acknowledging the loss, okay, they're expressing, they're crying, that's all good. So when they go through the denial, which is avoiding, the positive response to that is for them to cry. It's for them to say, this did not happen. So and so is not dead. I did not lose my house. I did not, they need to say it. That's actually a good thing, folks. That verbal denial is a positive adaptive response. Now, if you stay there for too long, that's the problem. Okay? You just can't stay there because you might have really did lose the job or the house or so you just can't stay there. At one point in time, we've got to, accept it. So now, maladaptive, they're not crying. They're not acknowledging the loss. There's a real NCLEX question where the woman loses her husband and she's at the funeral where she's helping everybody. Do you need anything? Do you need, is everybody okay? Like she doesn't even acknowledges. That's bad. That's maladaptive, okay? The second stage is anger. We have the little mnemonic DABDA, right? The second stage is anger. Yeah, we want them to get angry. Blame the nurse, blame somebody. Just be angry, right? Maladaptive is when they have persistent guilt, low self-esteem, aggression. Now, aggression means people are about to get hurt, right? Destructive behavior. Yeah, that's all maladaptive. It is not acceptable. Bargaining, they express wishes, okay, for the lost to return, wishes to be alive and stuff like that. Maladaptive is when they bargain with unrealistic expectation. Can a person come back and stuff like that? No, it has to be realistic for it to be adaptive, for it to be good. Depression, crying, they cancel dates they had and stuff like that. That's normal, temporarily, it's fine. And then the final stage is the acceptance, okay? They may want to withdraw a little bit, be alone, that's normal. They may limit, public stuff, okay? But they've accepted the loss, okay? So that's Zabda, okay? And that's Miss Kubler-Ross, Elizabeth. All right, new topic. Stages or characteristics of your relationship with your client. Remember, the only relationship you have with your client is a therapeutic one, okay? There has to be boundaries that has to be set. You need to make it clear with them, the terms of the relationship, okay? So we're going to talk about that. There's phases to the relationship. We have what's called an initial, a working phase, and then termination phase. Now, just like the med-surg floor, discharge starts on admission. Same thing here with the psychiatric patient. So the moment you meet them, you're orienting them, you're building that trust and that rapport, they need to know how long you're going to be together. Mrs. Jones, I'm your nurse. And we're going to be meeting every Monday, Wednesday, Friday from 10 to 2 for 3 weeks. You see how they know when, they know how often, they know the time, and they know when it's going to end. The end part is the important part. As a matter of fact, while you're in your working phase, one of the questions you need to keep asking your client, okay, is how do you feel about our sessions coming to an end? You want to continuously, ongoingly assess that because we're talking mentally ill clients. They may not be ready for the relationship to end. So as you work with them, you're diagnosing, you're fixing problems, you're evaluating, reevaluate, all of that. Mrs. Jones, how do you feel about our sessions ending in 2 weeks? Okay? So if they're not okay with it, you'll know, okay? Anticipate problems of termination. They may become dependent on you, okay? They may recall, other separations that didn't go well. Okay, you may bring back feelings of rejection, depression, abandonment. That has to be assessed. Okay, and if you find that they're not okay with it, you may have to add more sessions. But you've got to assess, and Plex questions you on that. Okay, so keep that in mind, everyone. Okay, so now as you build your therapeutic relationship, you must always consider the client's developmental level. Because you may have a 35-year-old who's mentally 5. Right? You need to consider cultural, spiritual, emotional, physical, all of that. Now, we focus more on objective behavior, not subjective, especially in this arena, because clients walk in and tell you they're the president, CEO of Visa Corporation, right? Or they're the president of the United States. They're the first lady. We don't just take that. No, we go by what we observe. We describe. Your opinion should never be part of your charting. Okay? The fact that you think, nope, don't do it. Okay? And we are more likely to share information and explore alternatives instead of offering the advice and solutions. We're going to go over that in a moment. We focus on the how and not the why. Why makes people defensive. Why didn't you log in on time? You see that? Versus, is everything okay? I didn't see you at our appointed time. What's going on? That's an open-ended question. It is much better than the whole why, okay? Now, there's been times when why is part of a question or an answer and it's okay. But if it causes the client to be defensive, it is not okay, okay? So be careful of that one, okay? And I mentioned earlier, we do open-ended, not closed-ended, because open-ended causes the client to elaborate. We want them to elaborate. We don't want yes or no questions. Did you sleep well last night? Yes. No. Mr. Jones, tell me how your night went last night. That's open-ended. Tell me how. He's going to give me detail. Well, I didn't go to sleep until 9. I really turned and tossed. I had to go to the bathroom frequently. I think it might be those medications. You see how it's open, right? Versus, did you sleep well? Yes. No. So you don't want closed-ended questions. Get rid of them, okay? Some more little tips for you here in the purple. Okay, but that stuff you can just read. Let me pull out NCLEX stuff. All right, so now some verbal communication stuff we need to go over right here. There's so much I need to pull out of here. Whenever you're doing a question, if the answer is you giving advice, I promise you it's wrong. Okay, and NCLEX doesn't do that. Like you'll get a question where it says, the nurse needs to reinforce. Okay, yeah, you're looking for something that they're saying that's wrong. Or the nurse needs to do more teaching. Yeah, you're looking for an answer that's incorrect. But NCLEX doesn't ask you, like they don't come out and say questions like, which here is like those negative type of questions. Like they don't do that. So whenever you see the answer is you giving advice, it's not correct, okay? So NCLEX wouldn't phrase it in the term where, I'm trying to give you an example. I have a practice question coming up so you can see what I'm talking about. I'll explain it then. So here, whenever the answer starts with, why don't you? I think you should. I believe you should. Those are never correct. Never, 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 okay? Telling the patient what to do is inappropriate. False reassurance. Oh, don't worry, it'll be all right. Dr. Joel is the best physician. You're gonna be fine. Oh my goodness, that's terrible. That's false reassurance. Those are never correct. Changing the subject. The client says, I'd like to die. And the nurse says, did you have visitors last night? First of all, you weren't even listening in this scenario, right? That's not therapeutic, because some of these psych questions, you're really asking yourself, what's the most therapeutic thing here to say? Okay, so if it's any of these, that's not therapeutic, okay? Because you'll see, I'm gonna be like, what's the most therapeutic thing here? There's like no teaching skills tip, nothing. What's the most therapeutic thing here to say? So no giving advice, no false reassurance, no changing the subject, no social responses, no cliches. There's light at the end of the tunnel. These are mentally ill clients. They're looking for light in a tunnel. Don't cry over spilled milk. They're looking for milk spilled. They take everything literally. Okay? So if you've never experienced this with mental ill clients, that's what's happening. So don't do that, okay? Some of you may not have had, especially if you did this under COVID time, you may not have gone to a mental health facility to see all of that we're talking about. Okay, don't overload them, don't underload them. Incongruent is when you're saying one thing, but your tone, the tone of your voice is saying something else. You're confusing these clients, okay? You can't yell to somebody and say, I love you. Okay, well, the words should be softer and kinder and sound a little loving, right? So that's incongruent. What I'm saying doesn't match my tone. As a matter of fact, you sound angry and yet you're saying you love me. What craziness is that? So yeah, don't do that to these clients, okay? Nothing judgmental. So sometimes you'll get clients who are non-compliant. It is our job to find out why. Yes, you are a little investigator, okay? Why are they non-compliant? Why? Why didn't you take your medication last night? Well, it constipates me. Okay, now we can add a cathartic. We can, have you take a Colace or something, eat roughage, walk, drink more water. But at least we know and we can intervene, right? So those are the type of things that you need to keep in mind. We need to explore the reason for the non-compliance. We need to understand, and we may need to intervene and make some changes. Okay? All right. Now, any questions so far? Because we are going to completely switch gear and get into psychiatric disorders. Okay? We're about to cover like schizophrenia, bipolar, manic episode, depression, all of that. We are about to jump into that shift. So any questions so far? All right, talk to me. Please say no, yes, throw me some emojis. All right, perfect. Okay, so this is the fun part, y'all. Neurotransmitters. A neurotransmitter is a chemical messenger that carries, boosts, and modulates signals between neurons and other cells in the body. So the fact that I can go ahead and pick up my cup and drink my water is because my neurotransmitters are within therapeutic range. I have homeostasis. So if you're not familiar with that word, let me break it down real quick. So homeostasis is where everything or that thing, something is within therapeutic range. And that's how life is. Everything needs to be within therapeutic range for it to function properly. So take our bodies, for example. We need the right amount of water flowing through our body. Too much, hypervolemia. Not enough, hypovolemia. And both are problems, right? Dehydrated, you'll die. Hypervolemia, you'll die. Your electrolytes, they all need to be within range, right? Your sodium, hypernatremia, a problem. Hyponatremia, a problem, right? Your potassium, hyperkalemia, a problem. Even with food, too much, gain weight. Not enough, anorexia, right? Death. So yeah, that's how life is. So now I mentioned your neurotransmitters earlier. I mentioned epi, dopamine, serotonin. So as we get into these disorders, you do need to know which neurotransmitter is either high or low, right? Which one is not enough, okay? So now our first disorder we're going to talk about is schizophrenia. So schizophrenia is characterized by delusions, which we're going to define. Hallucinations, we're going to define. They're very, very different. Disorganized speech, behavior, movement, the catatonic behavior, which is that motor immobility or stupor. We're going to talk about all of that. There's different types of schizophrenia. The one that we need to zone in to and talk about is paranoid schizophrenia. That's the one that NCLEX throws at you. Okay, that's the most common, well-known, but there are other types of schizophrenia, okay? So, couple of vocabulary words. Psychosis. Psychosis is when, okay, so like if you and I are talking layman's term, each other, no nursing, NCLEX, medical stuff, we're going to use the word crazy, okay? But medical terminology is psychosis. That's when the client has a combination of delusions with hallucinations or the speech or the movement issue. Okay, so the proper term, medical term you'll see is psychosis. Now, sometimes you'll see the word psychoaffective. What does that mean? Psychoaffective is when they have schizophrenia, okay, delusion, hallucination, the speech, whatever it may be, plus an emotional disorder. So they could have the schizophrenia with depression, right? With bipolar, with mania, so the emotional stuff, once it's attached to it, the diagnosis changes to schizoaffective. Affective is the mood disorder. Okay? So findings of mood disorder with schizophrenia. Okay, that's schizoaffective. Okay. Now, if you pull up the DSM-4, now we have 5, and I don't know what number we're on. Criteria. So often we think, you know, this is older people. I think that used to be. I don't think that's the case anymore. People know that this starts at a young age. There's a whole process to this. You know, folks are getting diagnosed a lot younger now than they used to. Actually, some research will say, you know, this started like in their early 20s. Okay, so that's just the way it is. Findings last 6 months or more. Okay, they're ruling out other stuff, and it involves a lot of hallucinations and delusions, which we're gonna go over. Those two words are so important. Okay, so let's talk about the delusions and the hallucinations. I'm gonna come back to the characteristics. So findings of schizophrenia, which you saw earlier, includes delusions and hallucinations. Let's do hallucinations first. So hallucinations is when the client is having the disorder that deals with their senses. You know what your senses are. Your sense of hearing, seeing, tasting, smelling, touching, right, or feeling. So those are all your senses, right? You know, now there's a sixth sense, right? Like your, anyway, that's not interesting. All right, so auditory. The client hears something that you and I don't hear, right? So that is the most important hallucination. Why? Okay, remember the whole why, right? I haven't asked you why. No, actually, no. We talked about why earlier, but from a different angle. So, you know, I teach you, you need to ask why. Why is auditory out of visual, olfactory, gustatory, tactile more important? Because with auditory hallucination, the client, the voice that they're hearing could be a command, right? To hurt themselves or hurt someone else. Right? So you want to dig into that. You want to put that little investigator hat on and say, you know, first thing, best thing, initial thing, priority thing is to say, what is the voice telling you? Sometimes in your questions, they'll tell you what the voice is saying. So then that wouldn't be the answer, right? But if in the scenario, you don't know what the voice is saying, the best thing, the initial thing, the priority thing is to find out what the voice is saying, because we want to know if it's, you know, a command that says kill the nurse and you're the nurse. Okay, you want to know that, right? So very, very important. And then this is one of those areas. There are a few areas in nursing and in mental health where there's no shade of gray. Like we go there, we don't play with it, we don't fraternize with it, we don't kind of sort of, we go there. If we think there's auditory hallucination, are you hearing voices? What are they telling you? Go there. I promise you that's the answer. I promise you you're right. That's the way it is. Don't pick the answer that kind of sort of, nope, go there. Go there, go there, go there. Another one is with suicide, which we'll talk about again because we're not there, where if you think, go there. Are you going to hurt yourself? You plan on hurting yourself. Like, go there. That's always the answer. There's no shades of gray with those areas. There just isn't. Go there. Okay? Don't forget that. Easy question if you just remember these concepts. Now, visual, they see something that's not there, right? Here's us, NCLEX, right? Don't play with these clients. Don't choose answers that makes the problem worse. Here's how you enter these, because there's a fine line. It is real to them. And we need to acknowledge that. Mrs. Jones, I understand this is making you a little anxious, but I don't see anything there. I understand that you're hearing these voices. They're talking bad about you. You know, they've shared what they're saying, but I don't hear anything. right? It is real to them, acknowledge that, but you don't hear it. Now, if you hear it and see it too, that's a problem. All right. Olfactory, they smell fire and there's no fire. Gustatory, their food tastes funny because you messed with it, right? You're trying to tickle the brain. Now, whenever you're dealing with a client with hallucination, you need to pick up on that in that question, right? Because the way you interact with them, care for them, provide for is different than a client who's not hallucinating. Because the client with paranoid schizophrenia who's hallucinating, you're the enemy, right? You're the one coming to give them this food that's going to control their mind. You put a chip in there, like stuff like that. So they're not going to eat stuff that you bring to them because they don't trust you. Okay, tactile, they see stuff on them. They see maggots, they pick, and they even bleed out doing that. So that's all hallucination. So you're reading your question and the findings deal with the senses. It's a hallucination. Now, when it deals with the mind, the thinking, it's a delusion. Ideal of reference, persecution, grandeur, jealousy. They think they're other people. They think you're out to get them, right? They have these thoughts that you're controlling their minds. You're putting thoughts in their minds, or you can take thoughts out of their minds, right? All of those are delusions, okay? And they may have associative looseness. They may make up new words that are not in the dictionary. They may have what we call echolalia, where they repeat after you like a parrot. Okay. Clang association is when they rhyme, when they talk. Some clients will do that. Word salad is when they put a bunch of words together that don't have any logic. It doesn't make sense. Okay. So that's delusions versus hallucinations. Don't mix them. Now let's go back. Characteristics of schizophrenia. This is the most important section of this whole psychiatric nursing. That is also tied to the drugs. So this is important. And so many students have had these questions. So wake up, everyone. Okay? After this, we'll take a break. Okay, you will have earned it. So listen up. So schizophrenia has different characteristics. Some of those characteristics fall under what we call positive symptoms. Some fall under negative symptoms, and some fall under cognitive symptoms. Why do you need to know that? Because some of your medications, your antipsychotics, typicals, atypicals, we're going to talk about, some of them only treat positive symptoms, and some of them treat both. Okay, so some clients will have positive symptoms where it's their normal function exaggerated. So the delusion we just talked about, we all have minds that function properly. Theirs is exaggerated. We all have senses. Theirs is exaggerated. We all speak, theirs is exaggerated, right? Disorganized speech, expression speech that doesn't make any sense, okay? Grossly disorganized or catatonic behavior, they pace, they rock, right? Unusual motor pacing, like they won't sit still for you. They'll sit, stand up, walk, sit, stand up, walk, yeah, and they'll rock, and yeah. So all of that is normal functions exaggerated, okay? Now the negative symptoms, those are normal functions too, but decrease, decline. Okay, they are the ones where they have what we call flat affect. You look at them, right? You and I all have expressions on our faces. Okay, like I'm looking at my children here. Sometimes you can tell who's happy, you can tell who's sad, you can tell who's mad, right? These clients, they have flat affect. You can't tell. You can't tell if they're happy, sad, mad, not, like they're just there, okay? Alogia is the inability to speak. Okay, evolution is the lack of motivation. You ask them something, Oh, okay. Like, okay, that's the lack. They're not motivated to do nothing. Nothing matters. Cognitive, you kind of can tell the concentration is gone, the memory's gone, difficulty understanding or remembering. That's all cognitive. Okay, so positive versus negative versus cognitive. Okay, remember this because the drugs, we're gonna get into the drugs. Oops, the other one's supposed to be first. All right, I have a wonderful select all that apply for you. Wake up, wake up. A nurse is monitoring a client who is having hallucinations. The nurse notes paranoid content in the client's speech, and he appears agitated. The client is gesturing at a finger on the television. Which nursing intervention are appropriate? Select all that applies. Now, you know you love the select all that applies. You're very excited that this is a select all that apply because you know your material and you know NCLEX is just testing to see how well you know that area and you know it well. All right? So, hallucinations, paranoid speech, they're agitated. Let's look at our STEM. What nursing intervention is appropriate for this client? Okay, they're gesturing at the TV and so, okay, so what's appropriate? Take your time to read each of them, but don't forget the little test taking tip that we've learned before. You need to treat each answer by itself. So is it appropriate to do in a firm voice, instruct the client to stop the behavior? Do you think that's going to help? Right? Reinforce that the client isn't in any danger. Sounds therapeutic. Acknowledge the presence of the hallucination. Instruct other team members to ignore the client's behavior. Immediately implement physical restraint procedures. Use a calm voice in simple commands. Throw some answers at me. All right, give me some answers, everyone. Okay. Okay. I know I flipped over the answer real quick earlier. Hopefully none of you saw it, but I don't think so. Yeah, the word firm, that's not therapeutic. That's not gonna help. You kind of pick that up. Ignore, right? Not therapeutic. My goodness, if you do number 5, there's a risk of you losing your license, right? Because we talked about us being least to most, right? Restrictive. Okay, so great question. But do you see how there's no need to fear these select all that applies? Here's another one. A client states that voices are telling him to hang himself. The nurse documents that the client is at risk for suicide on the basis of which of the following, right? So this is an easier way you will see these questions posed, right? The client tells the nurse, okay, that a voice, so you know that's a hallucination, but what type of a hallucination is this? It's an auditory and a command is giving. They're telling the client to do something, okay? So that's not intractable sense of hopelessness. That's not an intolerable emotional pain. This is not a delusion. It's a command hallucination. Exactly. So this is an easier way of how you'll see those phrases. And then I showed you a select all that apply way you may see those phrased, okay? So now imagine, folks, as we do these things where you learn the material, you see how questions are pulled from it, we practice questions together, you go after me and practice more questions, there's no way you're not going to be successful. Like, I just don't see it happening. So this is like great stuff. I love it. I love it. And I can see you doing well with what we're doing. A client states that he is able to receive radio waves from aliens because they place a computer chip in his brain. The nurse would document this behavior as which of the following in the medical records. So client is receiving radio waves, okay? Because he believes. So you know, right, that's not a hallucination. I don't see any sentences any senses being used here, right? They're not oriented. Reality oriented, that's right. Yeah. It's not an illusion, it's a delusion. Exactly. All right. So now some alterations in behavior, just some words you need to be aware of. Like bizarre behaviors, like we're talking about extreme motor. I give you some examples: waxy behaviors, automatic obedience. Sometimes you'll see these guys, they're overly obedient, right? So stupor, negativism, agitated. So that's all part of alter. That's not normal, okay? Some associated findings with some of these disorders: depression, suicide, okay, water intoxication, substance abuse, violent behaviors are all part of what we're talking about here, okay? So there's a little mnemonic somebody came up with. I think this one is from the Learning Express Library, I think was the one that came up with this one, where they have the word sober for you with 2 S's, S-S-O-B-E-R. Add another S to that just to help you remember it. As for the generalized characteristics of schizophrenia, self-care, often they don't get up, brush their teeth, wash their faces. Like, these clients don't do that, okay? Social adjustment is impaired. Yeah, they don't socialize well, okay? They're not oriented to their environment. Some of them just walk and pace like forever, you know, they don't have boundaries. Like, literally they'll walk up to your face, like right here, and talk to you type of thing. It's just, yeah, part of the disorder. They're very confused as to what's happening internally, hence the whole delusion and hallucination. Okay, reality, like literally, they don't know who, what, where, when type of stuff. Okay, so SSOBER, hopefully that helps. Now, I told you we're gonna zone in to paranoid schizophrenia. So with paranoid schizophrenia, they have the hallucination, they have the delusions. Okay, they don't usually have the speech issue, but they are very, 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 very suspicious of everybody. Okay, so now you have to keep that in mind, because the moment you see you have a client who's diagnosed with paranoid schizophrenia, you know what to expect and how to care for them. Okay, they're suspicious of you, the nurse. Okay. They bear grudges, they don't forgive, they think you're out to get them. So they're not the type whom you can walk into their room and say, here, Mrs. Jones, here's your lunch. No, they won't eat it. It has to be closed. They have to be the one to open it, right? You can't just come and give them their medication and they won't take it, because that pill that you've already opened up is something that's going to control their minds. Okay, the other thing too, these client needs, and you're gonna see, I'm gonna sound like a broken record as I cover disease after disease after disease after disease in this area. You're gonna see, I'm gonna say they need a structured, predictable, structured, predictable, structured, predictable. That's why when you go visit a client in the mental health unit, you will see a whiteboard somewhere, either in the break room, the main room, wherever they are, where you will see the date is always there. And you will see every hour what they're doing and what they're supposed to be doing. And it is consistent. They need a structured, predictable schedule. Here's another important thing, and remember this one. If the answer is you arguing with them, that's not the answer. Nope. Avoid arguing with them. You don't make them better. Give them options. Mrs. Jones, do you want the medication with apple juice or orange juice? If there's no contraindication, right? You want it now in 30 minutes. right? They think they're in control. Well, why don't you just give it to me now, right? I'll take it in half an hour here, right? You just want them to take it, but giving them that option makes them think they're in control. Okay, that's just how you deal with them. And Plex tests you to see that you know not to let them manipulate you, because these conditions, I'm going to talk about several one of them, they cause them to be manipulative. They'll tell you what you want to hear to get what they want, okay? So you need to know, well, Nurse Susie let me do it yesterday. Well, I'm not Nurse Susie. This is the policy and procedure of this facility and institution, and this is what's going to happen, right? You need to, put your foot down, because they'll manipulate you, okay? So keep those things in mind, because that's where your questions come from. So now let's go into the biochemical. The biochemical that is abnormally high is dopamine. They have too much of it. We need the right amount. What condition do you end up with when you don't have enough dopamine? It starts with a P. Throw that at me. You don't even need to spell it right. Just put it in the chat. What neurotransmitter, when you don't have enough of it, you end up with another condition that starts with a P? Now, I even gave you the acronym that it starts with. So what condition is that? Let me refresh. You know it? Not enough dopamine causes another condition. So that's why sometimes when clients are on some of these antipsychotics we're going to talk about, they look like those clients. I don't see any interest yet. Huh. Thank you. Yes, Parkinson's. So do you see the whole homeostasis thing? Right? You need the right amount. Too much, schizophrenia. Not enough, Parkinson's. So yeah, after some time on these drugs, when the dopamine level goes too low, these clients, look like a Parkinson's client. They start to have the shuffling gait, the pill rolling, and all that beautiful stuff. So the neurotransmitter that's acting up here in the schizophrenia is dopamine, okay? So there's some abnormalities with norepi, acetylcholine, and GABA, but the dominant one is dopamine, okay? So the other theories out there, Psychosocial says that, the clients with schizophrenia, from the MRIs and PET scan and all of that, shows that their frontal lobe of the brain seems to respond to environmental stress, okay, are extremely responsive to environmental stress. So those individuals, but the ones you get questioned on is the biochemical. So that's really where you should focus, okay? Because some theorists even say your, parents could cause you to become schizophrenic, but I don't see questions on that. More on the biochemical. All right, so we need to talk about your antipsychotics. So right here, we're going to talk about the atypicals and the typicals, okay? So we're gonna go to the charts that I have, because they're broken down beautifully, okay? But our job, your job, for all of these clients that we're going to talk about, okay, so schizophrenia just happens to be the first one, but our job is to protect, medicate, bring back to reality, and hygiene. Protect, medicate, bring back to reality, and hygiene. Okay, so we protect them from themselves, we protect them from hurting others, we establish a trust relationship. Oh, By the way, you see earlier I kept mentioning the only relationship we have with our client is a therapeutic one. So in a therapeutic relationship, trust is built, right? Now, just because we have trust, you need to know how to handle these relationships, because there's questions on the NCLEX where it tells you the client says, I have a secret, can you keep it? The answer is no. That's another area where we don't, no shades of gray, because they may really share a secret with you that you cannot keep. So if you say yes and you can't keep that secret because they're gonna harm themselves or other people, right? You can't keep that secret, then you have to break that promise, and that messes with the trust. Because who keeps secrets? Friends. And you're not friends, right? You're not your client's friends. So the answer to that question is always no, I cannot, but I would like for you to tell me anyway. Yep, I still want to know the secret. It could be something stupid, but it could also be something that's going to save your life. So nope, I cannot keep that secret, but I want you to tell me what that secret is. And it's so funny, students have told me in the past, what if they don't? Usually they do, but NCLEX doesn't go there, which is great. So protect them from themselves, others, protect others. Medication, we administer their medication, teach them about the side effects, teach them how to be compliant with it. We're going to monitor extrapyramidal symptoms. We're going to zone in on that in a moment, because some of these medications will cause extrapyramidal symptoms. So we're really going to zone in on that. So hang on. Reality all the time, right? Realistic goals all the time. When they accomplish that goal, we celebrate that, okay? We encourage them to do better, and then we elevate the goal. Like, we want them to, you know, God willing, go back to their state. I know a program that the county has. This is not NCLEX, right? You never know. I know a program that the county has where people that have overcome are now mentors to those who are, you know, at different stages, especially with detox and you know, from drugs and alcohol and stuff like that. But even with mental illness, I met a lady who, that's what she does. She was at this state where she got better and she's functioning in society and everything. And now she mentors other people. So pretty cool. Hygiene, assist with hygiene, feeding, encouraging self-care. We want them to do their activities of daily living. Okay. So that's our job. Protect, keep that in mind, because they'll help you get questions correct. Make a little mnemonic with it. There's no vowels there, but add one. Okay, protect, medication, reality, and hygiene. Okay, so now treatment. So yes, all the group therapy, long-term therapy, family focus, all of that will be a part of this, but there will also be antipsychotics. Okay, yeah, the medications have to be a part of this, especially if we're talking there's positive symptoms of schizophrenia. Yeah, in addition to the antipsychotic agents, at some point you will see the physician will add anti-Parkinsonian agents, and now you know why, because those dopamine levels need to be within a therapeutic range. Okay. All right, so let's go. Let's talk about the meds. This is really where so many questions come from. So your antipsychotics have two umbrellas. There's the group of drugs we call typical, conventional. They're the first group of antipsychotics ever made, right? And then there's your atypical antipsychotics. Those are the new generation antipsychotics. So let's cover your typical conventionals first. Your typical conventionals on the left side, they're going to work on the dopamine level in the brain to reduce it, because you know that's the problem, right? It's too high, we need to bring it down. So your typical conventionals, they're gonna decrease that dopamine in the brain. The problem is there's several problems with them. Not that they're not used, they're still used a lot, okay? But the problem with them, two problems. Number one, they only work on the positive symptoms of schizophrenia that we talked about. Okay, the hallucinations, the delusions. Okay, they only work on those symptoms. They do nothing for the negative and cognitive symptoms we talked about earlier. And in addition to only working on the positive symptoms, they cause these serious side effects. And that's what we need to go over, okay? Now, they cause agitation, agranulocytosis, anticholinergic effect, orthostatic hypotension, EPS, extrapyramidal symptoms. Like these clients get rigid and stiff, their muscles move without control, tremors, restlessness, sedation, tardive dyskinesia, especially when they're on it for like years, malignant syndrome. Let's dig in a little bit more into the side effects, and then I'll come back to the actual medications, okay? So now, extrapyramidal side effects of, let's pull out allopurinol, which is Haldol. So dystonia. Dystonia is that uncontrolled muscle spasm. Their face twitch, their tongue move, without control. Okay, so and this happens early, like within 1 to 5 days from starting the drug. Parkinsonism takes a little bit longer. Okay, they get rigid, bradykinesia, tremors, akathisia. Within about 5 to 60 days, they're restless, literally. Okay, they can't sit for a second. Like their butt will touch a chair, boom, they're done. Okay, neuroleptic malignant syndrome, muscle rigidity again, fever, and I'm talking about a high fever, people, not a low grade 101. Their core body temperature rises. Their blood pressure becomes unstable. So these are very dangerous, aren't they? Tardive dyskinesia. This one is a late one. It takes like even years for this to happen. Usually about 2 years, you start seeing this one. Involuntary painless movement of face and upper limbs. Literally, upper limbs just move. So those are from your, some more pictures here for you. Those are from your typical. Now, what are these typical drugs? You are very familiar with haloperidol, and that's why I picked that one to pull out, okay? Haloperidol. Add to haloperidol chlorpromazine. That's another popular one, thorazine. Okay, thorazine is chlorpromazine. In addition to thioridazine, trifluoperazine, flufenazine, thiaxine, haloperidol you're familiar with, melendin. Now, 1, 2, 3, 4. The first 4 end in azine, 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 azine. Okay, so you need to connect that to help you remember this stuff. Okay, and the side effects, I believe with the pictures will help a lot. Okay, and also keep in mind the time frame it takes for these to happen. So those are your typicals. You see how earlier I say pay attention to the whole positive versus negative, and this is why. Now your atypical, okay, they work on both positive and negative, and they have few side effects, okay, which is great. Oh, we love that. Yeah, makes life a little bit better. So those, you're a little bit familiar with some of them as well. Risperidone, which is Risperdal. Seroquel has a commercial, quetiapine. And aripiprazole, Abilify, also has another commercial. I think that's the one with the little hopping pill. Okay. A couple of them in done. There's one typical that ends in done, molendone. Okay. But most of your done, risperidone, this one, paliperidone, ziprazidone, geodone. See, there's, so most of your atypicals and then done to help you. Only one, molendone, is Typical, not atypical. But your atypicals, they too cause sedation, so both of them cause sedation. Hypotension, both of them, the dizziness, the weight gain is more with your atypicals, okay, but we'll take these symptoms over the whole tardive dyskinesia, EPS, and all of that as well, okay? So here's a question. A physician starts a client on the antipsychotic medication haloperidol. The nurse is aware that this medication has adverse extrapyramidal effects. Which nursing measures should be taken during haloperidol administration? Select all that apply. Yay! You're like, no. But you're going to change that to a yay. All right. So they're on haloperidol. You know the adverse effects of haloperidol. So let's go to our STEM. Which nursing measures should be taken during administration of haloperidol? So should the nurse review sub-Q injection technique? We'll talk about that. There's a few things to learn. Closely monitor vital signs, especially temperature. Well, that's just good advice for any medication, right? And we know there's that whole malignant syndrome with this one. Provide the client with the opportunity to pace. Okay, I don't know if I've mentioned this, but we don't stop them from pacing. We just don't. And the drug causes them to pace. So why would we stop them from doing that, right? Monitor blood glucose level. There's a lot to learn about that. We're going to talk about that. Provide the client with hard candy. The anticholinergic effect, we're going to talk about that. Monitor the client for signs and symptoms of urticaria. Okay, so throw me some answers. I'm going to give you about 30 seconds. And then we'll look up some answers. All right, can I get a few more of you to send me some answers? But because of time, we're gonna move forward. Okay, so let's go over. Who sent me those answers? Yes. Oh no. 4, 6. Okay, let's talk about it. All right. So okay, so nobody chose one. Perfect. Yeah, it's not sub-Q. It doesn't impact the glucose. And I think a few of you chose 6. It doesn't cause urticaria. Did anybody pick 4? No. Oh, no, one person. Okay, so yeah, it doesn't affect the blood glucose. The hard candy is for the anticholinergic, the drying of the mouth. 2, everybody should be good with. The pacing thing, you get that. Okay, the drug is gonna cause that. So don't stop them from doing it. Even with OCD, we don't stop them from doing it. It doesn't affect blood glucose and it doesn't cause urticaria. So it's 2, 3, and 5. Okay, I think all of you had 5 almost. 2, yeah, everybody's good with 2. Okay, so recap. Haloperidol is not given sub-Q. It doesn't affect the glucose and it doesn't cause urticaria. Awesome, great question. So now I like this little chart because it puts them next to each other as far as, you know, the pros and cons. Okay, typical antipsychotics are known as the first generation. I told you they're the first drugs made for mental health. For antipsychotics can cause extrapyramidal, you know that. The adverse effects are the bad ones. Fewer withdrawal symptoms. Okay, yeah. I wish they had put something here about the adverse effect. Okay. All right, so now let's take a break. And when we come back, we are going to go into the mood disorders. All right. So we talked about schizoaffective earlier. Affective disorders, we are talking about the mood disorders, okay? When we say affective disorders. So those deal with emotional reaction, okay, to experiences or situations, but emotional reactions that are inappropriate, whether it be exaggerated or diminished, it's inappropriate, right? So some common ones: bipolar, depression. You know, bipolar has depression and manic, right? Depression, postpartum depression, which is covered under health promotion OB. Cyclothymia type of disorders are seasonal, right? So with those disorders, they're less severe form of the actual bipolar we're going to talk about. Schizoaffective, you know, deals with the mood plus schizophrenia. And then there are seasonal affective disorders, which are really, you know, seasonal, and they're based on the client not getting enough sunlight. So those who live in places where it's always winter or the majority of the year is winter, that's where they see those disorders. Okay, so causes. So we're going to zone in the biochemical again, but there's other core causes. Your psychosocial folks are big in there with Freud and Seligman, who says you learn to behave that way, right? Beck says it's a whole cognitive thing, where Freud sticks to ego, superego, and all of that. So there's different theories out there. With your, I mentioned, like with cyclothymia being in different times and stuff, but it's less severe, whereas seasonal affective is definitely seasonal. It's in the name. Those, some people say, deal with your circadian rhythm, your melatonin level, your serotonin. So again, these have cycles, right? Your circadian rhythm, let me explain that. So the way we're built, the norm, what is supposed to be is you supposed to be awake, right, during the day and sleep at night. You have certain level of melatonin floating in your body during the day versus the night, right? Same thing with serotonin. So even with like your steroids, right, we tell you take the higher dose in the morning and the lower dose at night, is because that's how your body operates, right? Your circadian rhythm says sun's up, you're up, sun's down, you're down, right? That's your circadian, that's internally. But sometimes some of us mess that up. Like those of you who work night shift, you kind of mess up your circadian rhythm a little bit, okay? Because that's not the norm, generally how it is. You're not supposed to be awake at night. You're supposed to be sleeping. So that's what we're talking about with your circadian rhythm. So some of the cause or the theory is deals with your biological cycles, okay? The melatonin again, the serotonin, okay? So biologically, so melatonin levels increase with darkness, right? So that's why there's a lot of over-the-counter ones. As a matter of fact, the other day I went to go get one, and there's so many different options. My goodness, like I was so confused reading it all, trying to see which one is organic, which one is the best. And I was like, oh my God. So, and light, right? Decrease with the light. So those places where it's dark most of the time affects that, okay? Your levels rise before you go to bed. That's why we take it, so it could help us sleep, okay? Melatonin levels are lower than normal in depressed individuals. So that's why that's one of the treatments, right? Seasonal affective does have some type of connection with the melatonin. So, you know, I don't want to say proof, but yeah. All right, so types of bipolar. There's bipolar 1 and bipolar 2, NCLEX. Let's pull out some NCLEX stuff from these two. We already talked about the onset of these things, especially bipolar before the age of 30. Bipolar 1, the big difference between bipolar 1 and bipolar 2. With bipolar 1, the client has one or more episodes of major depression and one or more episode of clear cut, no doubt, manic episode. Whereas with bipolar 2, it was a bit of a hypomania. So bipolar 1, they do need to be hospitalized. Here's another difference. And bipolar 2, they do not. These bipolar 2 people, they function fine in society. As a matter of fact, a lot of them are very successful, very goal-oriented, business-oriented, get it done, get it, you know, they're very much like that. So they don't need to be hospitalized. I mean, a lot of them don't even need medication or anything like that. But bipolar 1, yes. Okay? So recap one more time. Bipolar 1, major depressive episode and clear-cut mania. So they need to be hospitalized. Bipolar 2, one or more episode of major depression, hypomania. Do not need to be hospitalized. Okay? So that's the big difference. Now, a bit more with your biochemical theory. The manic episode could be due to your GABA that we talked about. Remember with the GABA, the excitement in the brain and everything. So not enough, right? Possible deficiency of neurotransmitter GABA, but too much epi and norepi, too much dopamine, too much, okay? The electrolytes may increase. Now with depression, opposite, not enough serotonin, dopamine, norepinephrine. And sometimes the depression could be from debilitating disorders, right? Vitamin deficiency, your B complexes especially. Some say it's genetic, okay? So don't forget it happens in children because we always think that's an adult thing. It's not, okay? So when they're at their manic phase with bipolar, they have that persistent elevated mood. They're irritable. They won't stay still. They pace around. They walk around. They speak very fast. They have grandiosity. They don't sleep. Their speech are pressured. Their thoughts are racing. They talk about a whole bunch of things. They move from topic to topic. Okay, highly distractible. Okay, that's the manic phase. Like if you can imagine all that I've said, literally, I'm imagining somebody who I experienced with that, where we had to Baker act them a few times, and they've had manic episode, and they get, you know, violent, these folks. So you have to be careful of that. We're going to talk about safety measures. With depression, it's quite the opposite. So with manic, we're really afraid of them hurting themselves and hurting other people, right? Being very aggressive. But with depression, we're definitely worried about them hurting themselves. They're not so much of a threat to others. Okay. They have insomnia. Sometimes they end up, you know, just lying there, very flat affect, and all they do is think about, you know, harming themselves. They literally lay there. I want to die. I want to die. I remember many years ago, I had a client who was diagnosed HIV positive on our unit and become severely depressed, and he was at that state where he had that psychomotor agitation or retardation nearly every day. He just laid there. I'm gonna die. I'm gonna die. I'm gonna die. Sure enough, he did right before the holidays. So there's something to be said with your thoughts and mentality. You can't just lay there and just say that all day long. And as much as I tried to stop him from saying that, he just couldn't, you know, get over the diagnosis. So there's a lot we're going to learn about depression. There's a lot of questions about depression and the antidepressants. So we are going to spend a moment there. Now, you know, like your family of drugs, the one that has the most is your antihypertensives. Right behind that are your antidepressants. Okay, because we need to talk about SSRIs, SNRIs, MAOIs. Oh my goodness. So they're like a large family, a lot of cousins. Okay, that's just the way it is. Just so you know the difference between a full-blown manic episode and hypomania, I highlighted here. So, so you know, bipolar includes both manic and depressive. So at the manic phase is when they have that elevation, right? That speech, that racing thought. You can figure this out more. Hypo is not as severe. So they may have a little bit of elevated, but nothing, you know, extra, you know, that where we could point it out. It doesn't impair them from functioning socially. They keep jobs. Like I told you, they're successful people. Like I know a couple of bipolar 2 people, you know, who have had hypomania, and again, they're fine, they're successful. So let's talk about nursing interventions with them next to each other, right? In comparison. So when they're at their manic phase, again, we want to protect them, not just from themselves, but they're more at risk of hurting others because they get aggressive, right? They could get violent, okay? Both conditions, we want to not cause any extra stimuli, but for different reasons. For your manic people, we don't want that excess stimuli because they're already overstimulated, especially mentally, right? Your depressed folks, we want to be careful how we do that. We want to bring them back to their pre-state, but gradually. So this is these conditions where you're choosing stuff where it's just the client and the nurse. Forget that group stuff for these folks, okay? Forget that group stuff, all right? We're going to build a therapeutic relationship. Don't argue with them. We already talked about that, right? You're going to give them options to make them think they're in control. Do you see how I told you I'm going to sound like a broken record? Okay, because you need to know how to deal with these folks. Set, firm, consistent. Okay, no, I'm not Nurse Susie. This is not the policy of our institute. No, you know what I mean? Set firm. Don't let them manipulate. Allow them to vent, but it has to be in a positive way. Venting can't be you throwing the chair. That's not good. Yeah, I want you to talk, and yeah, but nothing where anybody is gonna get hurt. Now, manic episode, you know we're going to treat with lithium and quite a few medication, but we're gonna zone in lithium in a moment because there's so much to know about that drug. But based on the client that I just described to you, oh, if you have a question, go ahead, either raise your hand. Actually, when I'm in this mode, I can't see it, but as soon as I come out, I will, or you can type it in and you can send me questions privately. Like I see a lot of students have discovered that. You can send the questions privately if you don't want everybody to see it, or you can send it to everyone if you don't care. But yeah, go ahead. And if I need to go back, I will, okay? We already took a break. Somebody just said it's break time. No, we took a break, 10 minutes. That was a long time. Don't forget, there's so much to cover. That's why I don't give long breaks, even though we're together 4 hours. It's really a full 3 hours and 15 minutes of actual teaching. I just give the break enough for you to go to the bathroom. But yeah, and sometimes it could get a little overwhelming. But yeah, we did do a break. So based on this client that I just described, right? You see, this is not a client when they're at their manic phase that is going to sit for you and have a meal. They're just not going to do that. So you have to know that. So I tell you, you have a client diagnosed with bipolar in the manic phase, and you know, what's the best thing here for the nurse to do? It can't be to provide them with a tray of food. They're not going to eat that. You need to offer finger food. Okay? They won't sit and eat for you. They'll pace and 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 walk all day. Okay, and you also need to make sure you're giving them fluid all the time because they're at risk of getting dehydrated. Okay? And why is it important with the fluid? It's important with the fluid because they're on lithium. If being on lithium affect their sodium. But here's the NCLEX question and what you need to understand. The goal is not for them to stop taking or eating anything with salt. No, the goal is to manage and maintain, okay, their intake of sodium, okay? Let's talk about lithium. There's a couple of things you need to know. First of all, you need to memorize the therapeutic range, okay? 0.8 to 1.2. You need to commit that to memory. Absolutely. Okay? When their therapeutic range is above 1.2, like especially if it's like a 2.0, they're definitely going to be toxic on this. So you're going to see the nausea, vomiting, diarrhea, drowsiness, muscle weakness, tremors, lack of coordination, blurred vision tonight. Yeah, you're going to see those things. The moment because lithium has a thin therapeutic threshold, as you can see here. So we need to monitor it in the client's bloodstream. Okay, you know you're going to allow the pacing. Okay, you know you're going to allow them to vent. Another thing, we've talked about biographical data. So if you're ever reading a question and you see that it says the client is a female, you have to ask why. Why would I go out of my way to tell you it's a female client? Or I would just say you have a client, right? But if I go out of my way to say you have a female client, why? If she is sexually active, she needs to be on a contraceptive, right? Because she should not get pregnant while on lithium, because lithium is categorized as a class D category drugs. It does cross the placenta. It will cause abnormalities to this unborn child. So women should not get pregnant while on lithium, okay? So now let's move aside to depression. So with depression, we're afraid of them harming themselves, right? Not so much everybody else, because they don't have the energy. They're just laying there thinking about one thing and one thing only, right? So we're going to talk about suicidal precaution. We're going to talk about different types of suicidal precaution. Okay, we're going to talk about the antidepressants. Now, in general, your antidepressants take forever to work, weeks and weeks and weeks, and the client gets worse before they get better. And then when they start to get better, they have this burst of energy where you really need to watch them like a hawk, because that's when they now have the strength and the energy and the motivation to do it. So there is so many things. There are so many questions concerning this area that are just so vital. All those three things I just mentioned to you, NCLEX questions. You need to know the fact that the antidepressants take a while to work. Okay, as you see here, Prozac may take like 5 weeks. Some of them take 8 weeks to start working. The clients get worse in reference to their suicidal ideation before they get better. And then they get that boost of energy where I feel, nope, that's because they have a plan and ready to do it. So there's so much you need to know and to remember with this. So let's dive some more. So with the treatment, several treatments, lithium is one of them. Okay, lithium carbonate is going to be part of the regimen. So your atypical antipsychotics, we've already talked about. Okay, olanzapine, we talked about. Aripiprazole, Abilify, we talked about. Okay, Risperdal, risperidone. So as you can see, they're part of that regimen, okay? Especially if the client is hallucinating, right? Which is a positive. Now, anticonvulsants are part of that regimen too. Valproic acid, Depakote, we'll talk about again when we do seizure. Carbamazepine, Tegretol, lamotrigine, Lamictal, and oxcarbazepine, okay, are some of the anticonvulsants that may play a role. But specifically the antidepressants, we're going to zone in to the antidepressants because of the area that we're talking about. So I have several little mnemonics and charts that you're going to take a look at, because you know these clients, you need to remove the belt, you need to remove anything sharp, you need to remove the excess meds, right? Like this is a great little mnemonic to kind of remind you of all the craziness you need to keep in mind. So when you get a chance, go over them, okay? And I see so many NCLEX questions here as I look at, you know, these little mnemonics, okay? So please spend some time on this one. But there are a couple more things I want to pull out, especially with suicide prevention and precaution, and then we'll get into the antidepressants. So, you know, you need to pay attention to what these clients are telling you are doing, right? So they give you clues, right? Nobody's gonna miss me. They're putting their affairs in order, their living wills, their healthcare surrogates, they're giving away prized possessions, right? They give you warning signs. Some of them come out and say just nobody catch up on it. I'll give you an example, and only because I know like this is about what we're talking about. There's like an NCLEX component to this. So many years ago, I was part of this church where this young lady, her grandmother was caring for her and her brother because the mother was in jail. So the grandmother pretty much raised them, and the young lady ended up becoming extremely ill. She was in ICU for a long time, which was very taxing. So we all in the church took part of, you know, assisting her. My job was to pick up her son, her grandson, and take him to Vacation Bible Study, because I had my kids and I was the game director every Wednesday night. So I used to pick them up, bring them back home. So we all pitched in and we all raised money to pay for the rent and all that stuff. So everything was taken care of. And thank God the young lady got better, right? She recovered. She went through quite a bit and lost so much weight, but she recovered and she was alive. And I remember one Wednesday night we were doing VBS, Vacation Bible Study. No, this was Awana. This was Awana. And I was the game director. I was directing the game, and she came. She was like, "Oh, thank you very much for all that we've done." I was like, "Oh yeah, you know, no problem. That's what we do." And not long after that, I think it was like the next night or the night after, she overdosed on everything she had and committed suicide. So the thing is, no one was able to tell. Like, she was finalizing, she was saying goodbye, and I was young. I didn't pick up on it. I know better now, having so much experience now, but that's what was happening. So we do need to pick up on these signs and intervene. And remember, I told you with NCLEX, this is something we don't like, there's no shades of gray. We're gonna go there, we're gonna ask you, okay? And here's a couple more NCLEX questions. Whoever tried in the past is most at risk. Okay, your history puts you at risk. Okay, if you give any threat, if you're giving away prized possession. So you need to go over these, because that could very well be a select all out apply. Okay, so you got to pay attention to these things. Okay, let's talk about precaution. So there's minimal and there's strict, right? Minimal is where the client is always at your view. Like, I lean over, I can see them, right? Every 15 minutes, you lean over, you can see them. They reside in a common area, okay, during their waking hours. They sleep where they can be easily observed, and frequent documentation on them. If they have a visitor, we educate the visitor, we pat them down after the visitor leaves. If the visitor brings something, we check the bag, make sure it's nothing they can harm themselves with. We get rid of all that stuff earlier, the belt, the shoelaces, all of that has to go, right? In the mental health facility, even the wigs, like the women cannot wear wigs and stuff. So that's minimal. Strict, put your hands out. Okay, I know I can't see you, but once you put your hands out, this is how far the client can be away from you. And in your NCLEX question, that's called arm's length. Okay, it's about 6 feet. Okay, so patient can never be more than arm's length away from you. You put your hands out, I got to be able to touch you, right? So it's a one-on-one. Okay, even when they go to the bathroom, the door must remain ajar. They can't close doors anymore. Okay, they sleep where you can see them. So this isn't just when it's night, you know, good night, and then they're by themselves. Nope, they sleep with that supervision. And same thing, everything I said earlier. No shops. They don't get to go home. Either minimal or strict don't get to go home, right? You know how they get that pass to go home? They don't get that anymore. Okay. So that pass privilege, not until they're off that strict precaution or the minimal precaution, neither one gets to go home. Okay. And even the windows, you know, the utensils, nothing breakable, nothing glass, nothing plastic. So all of that has to be taken away, because folks will do these things if they're determined, and we don't want that. All right, the family member of an elderly client objects that restraints are being used to prevent the client from wandering to another client's room, especially in the evening. Which of the following alternatives to the use of restraint should the nurse consider? A, provide visual and auditory stimuli. B, use anti-anxiety medications as prescribed. C, assign clients to a room near the nurse's station. D, lock the other clients' rooms. These are really the typical questions you'll get. And you have to ask yourself, you know, based on the scenario, what's the most therapeutic thing here? Oh, okay. I like that question, Gladys. I'm gonna answer it after this one. Okay, the throw me some answers with this question. So you have a family member who doesn't want you to restrain their client, and especially the reason it's being done. So first of all, that's unethical. You cannot restrain the client just to prevent them from wandering around. Okay, restraints are a last measure. Okay, that can't be the first thing that you do. Okay, so yeah, great. I see you all got it with the answer. Yeah, see, put them next to nurse's station. Okay, now if they do become aggressive, and then yeah, you can restrain them at that point, but just to prevent them from wandering to another client's room, you cannot restrain them for that. Okay, somebody could sue you. All right, I have a question here, and I don't want to skip it. In reference to how the mood disorder questions will go. I don't think I have a sample, maybe at the end, because I have a ton of questions at the end of each PowerPoint. With the difference between 1 and 2, you'll get some examples of clear-cut manic episodes, okay, where the client is not staying still. You know, they may get aggressive, or they're pacing, they're rocking, they're, you know, short attention span. So that's clear cut, right? Where they need to be Baker acted. So that tells you that's a bipolar 1 client. Okay, but if they, sometimes I see where they use, like Kaplan has a question that's flowing through my mind since you asked this, where it says the client, you know, has a hypomania episode. So that way, you know, that's most likely a bipolar 1. But if they say clear-cut mania, you know that's a bipolar 1. The hypomania is a bipolar 2. Okay, so recap, let's rephrase. So with these questions, bipolar 1 versus bipolar 2, there's descriptions. We know they both have major depression, right? So just telling me that wouldn't tell me whether it's 1 or 2. It's with the mania and hypomania. So clear-cut mania is going to be type 1. Hypomania is going to be type 2. So that's usually how you differentiate between the two. That's a very good question. Yeah, stage 1 needs to be hospitalized and stage 2 does not. Correct. Nice. Fun part now, antidepressants. There's so many different analogies as to why folks end up depressed. So the cause is not really known, but several theory, and some of them deal with your neurotransmitters, you know that. So what they're seeing is that clients with depression have a decreased norepi, epi, dopamine, serotonin, right? So yeah, so and it kind of makes sense with us knowing what these things do, right? So with the antidepressants, there's so much teaching. So in general, it's so crazy why, okay, you're on the antidepressant to, you know, prevent like suicide, but at the same time, they're at risk of suicide. I know it's like a catch-22, but that is how it is. So the other thing you want to remember with antidepressants, you never want to abruptly stop them. You must taper down, okay? Because then they'll end up with a rebound effect, which is very dangerous. Okay, so Zoloft has a short half-life, okay? So Zoloft is mostly used with your elderly, whereas Prozac has a long half-life. So it's more preferred for pediatric clients. See how I do Prozac, pediatric, PP, but you do need to remember the generic names, which we're gonna zone in. So in our little chart, you see we made our way down from a few of these. So your antidepressants, unfortunately, has so many cousins. There's the SSRIs. The SNRIs are not even on here. They're on the next chart. SSRIs, SNRIs, MAOIs, tricyclics, and some of your atypicals. I know, it's crazy. I like this little chart too because it kind of puts them next to each other, colorful, and gives you the signs and symptoms. The only thing I don't like about this chart, from from Health Central is that I wish they had the generic names there. I think this would be perfect if they had the generic name. So maybe it's something you can print and put the generic name there, because the signs and symptoms are really great. And then it shows you all the different categories. But for teaching purposes, I'm going to zone in on this one. All right, so your SSRIs, selective serotonin reuptake inhibitors. Okay? So remember, you were low in serotonin. So inhibitors are going to allow the level to rise, right? And that's our goal. That's what we want to do. So your two most popular ones, sertraline, Zoloft, and fluoxetine Prozac, which I just told you. Fluoxetine we use for the children, the pediatric clients, and sertraline we use for the elderly. Okay, we don't really want to use paroxetine in the elderly. That would be like a last measure. Why, you ask? Because paroxetine in the elderly, well, when used in the elderly, causes anticholinergic effect. It dries them out. You know, they already have fear of being constipated and all that. So not a good option for them. Okay. But all these drugs are going to block serotonin in order to, so they're going to elevate serotonin, and they're going to block dopamine, because we want to elevate the serotonin in the bloodstream. Okay. So recap. Fluoxetine for pediatric, because its brand name is Prozac Pediatric, to help you remember. Sertraline is Zoloft. We prefer for the elderly. Paroxetine, we don't give those to the adults. Okay. And Lexapro is the other one in this category. Okay, your SNRIs. So this one works on serotonin and norepi, okay, to boost the levels in your bloodstream. Okay, that's venlafaxine, duloxetine. I see and You're very familiar with Cymbalta. So now this is what I would suggest also. If you're having a hard time with this, pay attention to the commercials, and then pay attention to the generic names during the commercials, okay? So not too much you need to remember with this one. Increases suicidal rate, but your tricyclics increase suicidal rate more than any of the antidepressants, okay? Norepi and epi, again, that's just to elevate those two, norepi and dopamine in your bloodstream. So Wellbutrin is a good one. It's gonna inhibit the uptake of both dopamine and serotonin and norepinephrine. Okay, but if it's a male client, you wouldn't want to give them Wellbutrin, bupropion, because if they're young, they may want to have children. It causes libido problems, so don't do it. Tricyclics, amitriptyline is very popular, Elavil. A lot of physicians prefer that one. Now, all of your tricyclics may cause anticholinergic effects, right? The dry mouth, constipation, contraindicated with glaucoma clients. So all of that. And the tricyclics really increase risk for suicide. So be careful with those and watch these clients. Now, whenever a drug has dietary maintenance, I like to call them high maintenance, because you can't just give those drugs and not teach, okay? A couple of them would be like lithium, we just talked about. Digoxin is another one. Coumadin is another one. Your MAOIs are another one, right? You cannot just give, or the physician cannot just prescribe phenelzine and not educate, okay? Because what happens is, I'm gonna come right back to this. Let me get to, because some of you are visual learners. You have theramine. Theramine is an amino acid. What does theramine do? Theramine elevates blood pressure by causing vasoconstriction, okay? So your MAOIs, okay, your monoamine oxidase inhibitors, they block monoamine oxidase, right? Hence their name. And your monoamine that they're blocking is serotonin, epinephrine, norepidopamine. Those are the things that would raise your blood pressure, right? So MAO is an enzyme that's gonna break down any extra tyramine that's in your body. So because it's breaking extra tyramine that's in your body, that causes these clients to have that hypertensive crisis. Okay, so when they eat food that's high in tyramine, okay, because again, tyramine is an amino acid that elevates blood pressure, and that's gonna get broken down in your body. So that's gonna cause that hypertensive crisis. So there are a lot of food that are high in tyramine, and you do need to spend a moment there, because these are the type of questions where they tell you the client is on Parnate, Marplane, Nardale, and then you need to pick a tray for them, right? Those are the type of questions. So you do need to know Swiss cheese, Parmesan cheese, blue cheese are the aged strong cheese that are high in tyramine. Anything curd, anything preserved with salt and nitrate, sausages, cans, pepperoni, salami, anything smoked, anything processed, pickles, fermented food, those sauces, soy sauce. Don't you know when you eat these things, your blood pressure goes up? You don't even need to be on MAOI, right? Some of you are cracking up. You're like, yep. In addition to that, some medications, over-the-counter medications, are high in tyramine, okay? Dextromethorphan, okay? You can't just go and get you some Benadryl. No, you can't just go and get you some Sudafed or Dayquil. Now, certain diagnosed, you already know you can't take these over-the-counter medication. And I'm gonna get an example of that. So I caught a head cold the other day. It was horrible. And this is an NCLEX question. This is why I'm going there too. Otherwise, I wouldn't bother. So I recently changed my bedroom, and for some reason, I ended up under the vent. So that's how I got the head cold. For 2 days now, I was like, what happened? Like, what caused this? And then it dawned on me. So I switched the room back, right? Silly me. But that head cold, so here's the NCLEX question. I have glaucoma. So I can't just take anything over the counter because so much contradicts with my glaucoma. But as I go through my cabinet and losing it because I couldn't breathe through my nose, right? I'm not a mouth breather, I'm a nose breather. I was like, I saw Sudafed. I just took it. Because I just needed to, you know how you just needed to pop that pressure? It was all here, just a mess. I'm just now starting to feel a little bit better. Actually, it started last week when we were together, when because I switched the room on last Sunday. So I've been a mess since then. I'm so much better now. But I should not have taken that Sudafed, okay, because of my glaucoma. So the pressure, my intraocular pressure increased. I could feel it. Bad me. So similar analogy here for your NCLEX question. So you have a client, a Nardale, Parnate, Marplane, whatever it is, they can't just go and take Sudafed like I did, right? They can't just take the Dayquil because they have a cold. They need to take something that doesn't have a lot of tyramine. Now that's where your NCLEX questions come from in reference to MAOI. In addition to the food, the medication, your adrenergic beta blockers are part of that list. Like there's just it's all here. There's just so much teaching, as you can see, affiliated with this, right? So you've got to zone in on that one, okay? Not too much with your atypical antidepressants. The only one under that umbrella is trazodone, okay? Sorry about the noise. Okay, sorry about the noise. The machine went berserk over here. Okay, so let's try this question. Oh, you're welcome. A client is ordered sertraline. No, I threw that on purpose. Which is an SSRI. Which adverse effect should the nurse include when creating a medication teaching plan? Select all that apply. Yay! All right. So it's in SSRIs. What are some of the adverse effects we should include when creating a medication teaching plan? So I throw this at you so you can see how, you know, even though what we're doing together is great, but you still need to zone in on each and every one of these drugs, or at least their families in their class, right? Because if you don't know sertraline really well, this question becomes difficult. So you must go back to more than even what I have here. Because if you look at the SSRIs, I don't have all of them here, but that's why I put this little chart here for you. So you can see the other signs and symptoms: sweating, indigestion, headache, dry mouth, drowsiness, sexual effect. So that's why I like this little chart there, because you do need to zone in questions like that and memorize some of this stuff, okay? That's where it gets difficult, okay? So agitation, sleep disturbance, and dry mouth. Agranulocytosis would be more with a typical antipsychotic. SSRIs don't cause intermittent tachy or seizures, okay? After interviewing a client diagnosed with recurrent depression, the nurse determines the client's potential to commit suicide. Which factors should the nurse consider as contributors to the client's potential for suicide? Select all that apply. 1, psychomotor retardation, impulsive behavior, overwhelming feelings of guilt, chronic debilitating illness, decreased physical activity, or repression of anger. So really, if you rephrase this question, they want to know, you know, that you can pick up on some of what would cause these clients to be at risk for suicide. So just for time purpose, because I just looked at the time, impulsive behavior would be 1, okay? Obviously, overwhelming feelings of guilt, I'm sure you got that one. The chronic debilitating illness. Decreased physical activity, no, wouldn't put you at risk for suicide. Because then the majority of the population would be, right? How many people actually exercise? Not a large number. Repressed regression, yes. Holding it all in, that's why it's good to vent. Okay? Great question. A client is beginning treatment with an antidepressant medication. The nurse will include appropriate teaching strategies and precaution in the care plan, knowing that there is a high risk for suicide with medications in which of the following antidepressant classes. So I just mentioned that earlier. The highest one is the tricyclic one, okay? So if they're taking any of those, then yeah, they're at highest risk. We went over the tyramine stuff. Oh, okay, let's do this question. It's hypertension, but a client with asthma has started to take beta-adrenergic. The client also takes an MAOI. So this is an easy question where they put that the client takes an MAOI, or I could replace that with an actual brand name of an MAOI, right? To make it a little bit harder, okay? So the nurse assesses the client for which of the following? The hypertension, okay? Because they're on a beta-adrenergic blocker and an MAOI, so they're at risk of hypertension. And we're talking like high blood pressure. So here's another way they would phrase this MAOI question. Which of the following foods should the nurse suggest a client avoid from the menu when taking MAOI? Again, I could make this more difficult and replace the word MAOI with an actual generic name, right? So the blue cheese is the problem, okay? So no blue cheese. Avoid. Okay, just making sure. I don't like the smoked fish there either. I may have to change that because that might throw you off. But it's the blue cheese. No blue cheese. Okay, ECT is, so this is for like one of the last treatments that would be used for depression. So other measures, here's the NCLEX question concerning ECT. Other measures have to have happened and taken place and be unsuccessful for you to be using an ECT, okay? Extraconvulsive therapy. High success rate for treating depression, but used after trying or in conjunction with other treatments, okay? All right, OCD. Obsessive compulsive disorder. Here's what's happening with OCD. So with OCD, there's two components. There's the thought process, and then there's the action process. The obsessiveness is the thought, okay? 1, 2, 3, 4 ceiling tiles, 5, 6. Oh, I messed up. I'm a bad person. It's time for me to wash my hands, right? That's the obsessive part. The compulsion is what the person does. Okay, the hand washing, coming home and turning off the light, coming home and fixing the bed like a gazillion times, you know, and the compulsion and everything is not a big deal unless it's affecting their lives. You know, quite a few people have OCD, okay, NKJV. So your job, our job, is not to stop them from the behavior unless it's self-destructive, right? If it's self-destructive, of course, we're going to do it, right? Even the little ones, like the children that headbang, we pat the walls, right? We don't even stop them from doing it. The nail biting, hair pulling, all of that, you know, the hand washing, we keep the hands moist. And then some clients, you know, they move on, they get over it. But here's an NKJV question. There's no medication for the actual OCD. What you're treating when you're treating something is the underlying anxiety, the underlying depression, the underlying, right? There's no pill that, yeah, because there's different forms of it. So you're looking at the underlying issue. And whenever that anxiety, whatever it is, go away, you know, the compulsion goes away as well. And I can give you an example. My oldest son had OCD, he's right here, with closing doors and windows. And I'm talking every door. And I bumped into doors because he closed them. So I remember one particular time I come out of the closet. It's a walk-in closet, and literally by the time I turn around to go back in, he had closed the door, and I walked right into the door. And I'm here screaming, "My God, why'd you close the door?" But yeah, you couldn't leave doors open, windows open. I think he's over it now, hopefully. My husband has OCD with the washing machine. He's always washing something. So there's different OCD. I'm trying to think what mine is. I don't know. Help me think about it. So I may have one or I may not. I don't know. Do I have any? Some people think I'm a perfectionist, but I'm not. Okay, I realized, it's so crazy, a little bit NKJV here. I realized that, okay, so I was sitting in front of somebody one day. I was in their office, you know, their space, their environment. And as I sat down at the desk, I fixed their file because it was just on the table. And I'm like, well, why can't it be straight like this? And I'm like, what are you doing? I had to stop myself. So that would be like a perfectionist type of thing. So I work on that. So I'm very much aware of it. Some of you are just cracking up. Oh, that is not NKJV. I don't think perfectionism is on the NKJV. No, I don't think so. All right, so back to OCD. So these clients, you need a predictable structure. They like that, and keep it that way, because when you know, mess with that, you kind of mess them up. So here's a typical question from this area. A nurse recognizes improvement in a client with a nursing diagnosis of ineffective role performance related to the need to perform rituals. Which behavior indicates of improvement? So you know you're looking for something good, right? Because of the word improvement, something got better. So let all that apply. So for the sake of time, we're just gonna go through these answers. So it would be the client refrains from performing rituals. That's good, right? They got better. The client verbalizes that he uses thought stopping when the obsessive thought occurs. Exactly. You see how at the beginning of psychiatric nursing, we were saying that some theories said, you know, that cognitive behavior stuck with your mind and your thinking. I do believe that there's some truth to that, but my belief in stuff is biblical. But yeah, there's some truth to that. The client verbalizes a relationship between stress and ritualistic. Yeah, when they get stressed, they do that. So the rest are incorrect, but let's read them anyway. Avoid stressful situation. No, because sometimes they can't avoid them. Rationalizes. No, you're making excuses. That's negative. performs ritualistic behavior in private, you're still doing it. So I love this, and you're able to tell. And the more you practice these, I went and purposefully pulled out some Select All Out Apply, I believe. These are mostly from the NCLEX 4000, okay? Anxiety disorders, okay? So let's go over these. There's 7 of them, but I'm gonna pull out the most important ones. One very important one is PTSD, post-traumatic stress disorder. So there's a decreased ability of GABA. Again, we've talked about GABA so many times to decrease that anxiety. Okay, your norepinephrine system mediates your fight and flight response. Okay, and that anxiety comes up. So serotonin is also an issue. Drug of choice for PTSD are your SSRIs. Okay. So that's going to be what the physicians will bring in to treat PTSD. So now findings. Now remember, with post-traumatic stress, the client had a previous experience that was traumatizing and they're reliving it. It is real to them, even though they're just sitting on their chair in their couch, right? They're there in that moment reliving it. Okay, so keep that in mind. It's real to them. They have a sense of fear, dread. They feel powerless, they're crying, irritable, and depending on what it is and who it is and what the trauma was, this could get dangerous. So for example, if you're dealing with like a veteran who in his mind is back at war, you're the enemy, right? So there's been incidents where these folks strangle their spouses in their sleep, type of thing. So there's things that they have to do when they come home. They can't sleep in the same room. They got to remove the weapons and things like that, right? That's how serious this is. And I remember, just so you remember some of this that I'm telling you and your questions and stuff come up. I remember seeing on the news, this was during the time when COVID first started, where there's this billionaire who is funding research for PTSD, and they're concentrating on the veterans, where they use horses to help these folks with the PTSD. Okay, so I thought that was pretty cool because he's funding the whole thing. Apparently, you know, there is some the research is showing that the horses help, you know, folks with PTSD move forward. So that was pretty cool. And again, he's a billionaire, so that's a good way to spend your money. Right, so that was just focused on that. But yeah, the veterans. So sometimes I see your questions where, yeah, it's a veteran in your question. So we're also going to talk about interventions, okay, and treatment. So nursing interventions. What do we do? How do you handle it when they're not state, right? So first of all, decrease stimuli. Always decrease stimuli, right? No noise. Turn off the television. Any excess, anything has to go. Okay, stay with them unless they get violent, then everything changes, right? Acknowledge what's happening, what's going on, because again, it's real to them. Don't touch them. So often in your questions, I see like the stuff that the woman is saying, or the spouse is saying to the nurse. You know, like one question is going through my mind where the client calls the nurse and says, you know, my husband is yelling and screaming, telling me not to touch him, and I didn't do anything. Like, what do I do? How do I handle this? If the person say, don't touch me, right? So that's something that you need to keep in mind. Don't ever pick answers that shows, you know, any contact with the individual while they're in that state of mind. Okay, allow the temporary dependence because it happens. Speak calmly and slowly and clearly. Okay. And again, if they're venting, let them vent. All right. But treatment, the anti-anxiolytics, also, because we got to decrease that anxiety. Okay, so now we need to talk about substance abuse. New topic. So we've talked about quite a bit so far. Any questions on those? We're just about done. We do have some really important ones to cover. The eating disorders are important. They're coming up. And alcohol abuse is coming up. There's quite a few questions with alcohol abuse. So we're getting into that area. So psychoaffective substances. So with substance abuse, you do need to pay attention as to which substance they're abused obsessed with. Okay, because it matters. It matters in the sense of withdrawal. It matters in the sense of if they overdose, what do you do, or what body parts? It matters. So pay attention. Is it an amphetamine? Is it alcohol, which we're going to talk about? Is it a cannabis, marijuana? They don't question you too much about that. The questions from what I'm talking about deals with the opioids, okay, versus the sedatives. All right. Crack cocaine is in a category all by itself, y'all. All right. So the opioids are the cocaine, heroin, Demerol, morphine, OxyContin, right? These are streets, right? And these are prescribed. So, but either way you overdose on these, there are some measures that you need to know. With your sedatives, those are your barbiturates and your benzos that we talked about earlier. Now, they both give you a sort of a high, but the high that you get from them are different. And that's what I'm talking about. Let's do this question and then I'll show you. A client is reporting vague dread. She is pacing and hyperventilating. Her jaw is clenched and she is wrenching her hands. The nurse concludes that this client is in need of which following type of medication? So she's having anxiety. She needs an anxiolytic. Okay, very simple question. Okay, so this is, you know, in the family of drugs. Okay, so we're getting into the substance abuse stuff now. There's just a couple of vocabulary words that I need to pull here. So when it comes to substance abuse, so, you know, so often clients didn't set out or plan to become addicted. It happens. So first they start to abuse, where they're using the drug more than a month after when they no longer need it. Okay, that is abuse. You don't need it anymore and you keep taking it. That's abuse. So they become dependent, right? So they have an impaired ability to control the use. And if they don't get it, they start to withdraw. Okay, there's different type of dependence. There's psychological dependence, where it involves a craving. There's the physiological, where when they don't get it, they start to sweat, right? And then there's tolerance, where they need more and more and more and more and more. So those are, again, just vocabulary words, okay? So now, stimulants versus depressants, okay? So again, your stimulants are your cocaine, crack, amphetamine. Your depressants are your barbiturates, tranquilizers, your benzodiazepines, all of those. Now, they cause different effects, right? With the stimulants, they give you a different kind of high versus your depressant. Your stimulants, mood swings, dilated pupils, cognitive function seizures, whereas with your depressant, they give you like a high-low. Like with your stimulants, it's a high-high. With your depressant, it's a high-low. I don't know if that makes sense. Slurred speech, lack of coordination, withdrawal, cognitive impairment. It's like a high, like a, right? Where the other one is kind of like a different kind of high. So that's one way to think of it. Here's the other NCLEX part. Now, when clients overdose on a stimulant, it affects them cardiac-wise. So they're more, it's more where you need to initiate CPR. It's more the heart being affected, whereas when they overdose on a stimulant, you're thinking more of the respiratory is affected. They need respiratory support. You see, that's a big difference. So when they overdose on stimulant, CPR, right? Cardiopulmonary, versus when they overdose on a depressant, respiratory depression. Okay, so because they're gonna go in a coma and stuff like that. So you can't keep them awake here, and their heart will fail here. Okay, so very different. All right, with the narcotics, especially like with heroin and stuff, don't forget the pupils get constricted. Now, the part I want to pull out here in addition to that is when you have a pregnant woman who's addicted. So don't forget the baby's addicted as well. So the baby needs to go through withdrawal, okay? So it's very unique how that's handled. Withdrawal is handled with administration of the drug and then tapering them down. but it's not the street version, right? Right? It's the synthetic lab made version. So, but they do get drugged up, right? And then it gets tapered down. Because if you allow the body to just cold turkey like that, a lot of folks just can't handle it. The heart can't handle it. The systems cannot handle it, and they end up passing away from that. Okay, so you do need to keep that in mind. Okay, of course they need rehab and stuff. All right, let's zone in alcohol abuse. So now we're not talking social drinkers, Happy New Year, once a year. No, we're talking about alcoholics. They get up, they drink, right? They drink for breakfast, lunch, and dinner. They drink. So your chronic alcohol users, first of all, this is impacting the liver. They're going to end up with lymphatic cirrhosis, right? But some of the other findings are the anemia, hypertension, tachycardia, gastritis, malabsorption, fatigue, cognitive impairment, tremors. We could go on and on. In addition to that, I want you to add this one, Wernicke-Korsakoff syndrome. So Wernicke-Korsakoff syndrome is a form of amnesia that happens with chronic alcohol abusers. They lose their short-term memory, right? Now that explains a lot, right? And this happens because of a vitamin that they become depleted of. I'm going to come right back. They get depleted of their vitamin B, their thiamine, okay? B1. So that is part of that banana bag, right? That is part of the cocktail that we give them for during the withdrawal process. So now there's different levels to the withdrawal. So first of all, if you admit a client into the hospital and they tell you they're not going to stop being an alcoholic, you need to give them the alcohol, because if you don't give it to him, they will go through withdrawal. That is why the moment you admit an alcoholic, do you drink? Yes. How often? Every day. Your next question would be like, okay, you're dealing with an alcoholic. The next best thing to ask them, that's an NCLEX question, is when was their last drink? Because you need to know when they're going to start to go through withdrawal. Okay. And within 48 hours, the withdrawal start. When it gets to 72 hours, it is at a dangerous state. They're at risk of delirium tremens, okay? It's a severe form of alcohol withdrawal, occurs about 72 hours later. They're at risk for seizures, severe mental changes, agitation, confusion, delirium, hallucination, right? So the moment you admit this alcoholic person and they're gonna go through withdrawal on your unit, you need to put them on seizure precaution, pad the side rails, have suction and oxygen at the bedside, right? In addition to that, if it's up to the physician, some physicians choose to not allow the client to go through withdrawal on their unit, so they will give them the alcohol. As long as you give them the alcohol, they won't withdraw, right? So that's why sometimes in the hospital, you'll see the client will get a beer with breakfast, a beer with lunch, and a beer with dinner, okay? Because we don't want them to withdraw. But if they do decide they're gonna let that client withdraw, I had this was many years ago. I had a client who lied on admission. He didn't say he was an alcoholic, and yeah, about 2-3 days later, he started to go through withdrawal. We had to restrain him. He was having tactile hallucination, all of a mess. So he did end up going through withdrawal with us. He had a broken arm, so we couldn't even do the surgery because of that. But yeah, he was the typical book one. So I admitted him and I had my 2 days off. When I came back, he was like restrained. And I'm like, Martha, what happened to my guy? I go, hello. She's like, oh yeah, he's an alcoholic. I'm like, get out. I had no clue because he lied. So sometimes they do that. And yeah, he ended up going through withdrawal. It was right before the holiday. I remember him like it was yesterday. So he went through the whole process. So mildly, they have that insomnia, anxiety, some GI upset, not a big deal. But by the time they get to moderate withdrawal, they're having the tactile hallucination, they're having tachycardia, like all of that, the sweating, all of it. Now, at severe is when they're at risk of that seizure. So they should be on seizure precaution, okay? And again, because they're so at risk of delirium tremens. So now let's treat these clients. Okay. So there's treatment for the acute phase and there's treatment for the long-term phase. For the acute, we're worried about the seizure. We're worried about the hallucination. So you'll see benzodiazepine as part of the regimen. We talked about diazepam already. Yeah, we were talking about it from an anti-anxiolytic standpoint, but here we're going to bring it in for the seizures. It will help with the anxiety. And then we're going to have some typical antipsychotics because of the hallucinations. Okay, that's why Haldol is there. Long term, we need to take care of the craving. And these two, maltrexone and nalmefene, takes care of the craving. But let's talk about disulfiram. Disulfiram in abuse, first of all, you're not going to start that drug until like a good 4 or 5 days later, because the alcohol needs to be well out of the client's system. Because if it's not, they will end up ill. As a matter of fact, once this is prescribed, there's a lot of teaching. You need to educate this client. You cannot touch alcohol, smell alcohol, come near alcohol. So no more the mouthwash, no more the paint alcohol base, nothing alcohol, right? Because they will get ill. And that's the whole point. We want you to hate this stuff, right? And of course, you want to refer them to the Alcohol Anonymous. There's classes for the spouses, Alateen and Al-Non or something like that. So those are the priorities with these clients. So here's a quick question. A client is receiving Librium, right? Chlordiazepoxide, long name, who came up with that? To control the symptoms of alcohol withdrawal. So sometimes you see Librium as part of the regimen. The chlordiazepoxide has been ordered as needed. Which symptom may indicate the need for additional dose of this medication? So we need to add more. I love these questions because it just shows you different angles of how these things could be phrased. So this stem is a little bit unique. I don't think we've seen a stem like that before. So which symptoms may indicate a need for additional dose? So this drug, we need to give more of it to have its therapeutic effect. Okay, that's really what this question is saying. For time purpose, I'm not going to wait for you to chime in with me because of time. So tachycardia, okay, elevated blood pressure and temperature, tremors, and increasing anxiety tells us that are indicators that we need to increase the dose. So the physician will do that. Not the mood swings, doesn't tell us that. Piloerection doesn't tell us that. So the elevated BP, the tachycardia, so they're still having some of the symptoms we want to lower, right? Tremors, the anxiety, we want to lower those. So this is a great question. It kind of reverses your thinking. Which of the following is the highest priority for a client after withdrawal from alcohol and beginning the use of disulfiram? Okay, no more alcohol, right? Abstinence, just in case you didn't get it. Yeah, the social part, that's Maslow, yeah, no, not priority. Learning about the disease, no. No more alcohol. You're gonna be in trouble if you drink alcohol. No more alcohol. Having requested it as part of the comprehensive treatment program, the client is receiving disulfiram. Which statement should the nurse include when teaching the client about this drug? So the whole no alcohol thing, this, the whole uncooked seafood, yeah, that's not what disulfiram. No, disulfiram is not for the craving, okay? No, it's not going to cause rapid intoxication. It's going to cause you to be ill. So inhaling fume from paint and wood stains, because those have alcohol, okay, is going to cause them to be ill. I like how we throw some other stuff here. All right, new topic, eating disorders. We're almost done. Hang in there. And I know we practiced quite a few questions in between, which is great. Eating disorders. So let me just cover pica real quick. It doesn't really fit under this umbrella. It's more of an OB question usually when you see pica. But in general, pica is not good. Is when people eat non-nutritionist, I don't want to say food because they're not food, non-nutritionist substances like dirt, baby powder, detergent, toilet paper, like stuff, right? Those are not food. So like, I can't say food. And it's dangerous when they're pregnant, right? It's even more dangerous rather when they're pregnant. So that's pica. We're going to focus on these two, anorexia nervosa and bulimia. So anorexia nervosa is when the client has a fear of obesity. They refrain from eating. They don't eat. They live on a peanut for like ever. And they look in the mirror, they see a fat person, but yet we can see their clavicles, we can see their rib cages. They've lost a lot of body weight and fat. They've lost so much body fat that they don't get their period. So they have something we call amenorrhea. Okay, when you lose too much body fat, women do not menstruate. So they have amenorrhea. So they're the ones, anorexia nervosa, that refuses to eat. Okay, bulimias, they eat and 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 they eat. That's called binging, right? They feel great when they're eating, so they'll eat and eat and eat. After they eat, their mood goes down and then they purge. That's why the picture next to the bathroom, right, next to the toilet. So the bulimias are the ones you need to follow to the bathroom because they're going to go purge. So bulimias have the binging and purging. Okay, bulimias binge and purge. And the other thing with bulimias you need to remember, they're not usually skinny. They're usually normal weight or overweight. Okay, they're not skin and bones like you see with anorexia nervosa, with the nervosas. So a couple more things. So if you put them next to each other, so your anorexia nervosas will refrain from eating, where your bulimias will eat. Anorexias don't usually purge. There's nothing to purge. Bulimias will binge and purge. So a couple of questions. They're both at risk of electrolyte imbalance, malnutrition, all of that great stuff, right? But there's some differentiation. So bulimia clients are the ones with the calluses. Why? Because they stick their finger down their throat, right? So they're the ones with the calluses. They're the one with the tooth decay because of what they do, the binging and the purging. The purging causes these two things. So these clients, like your bulimias, they're at risk of metabolic alkalosis because all that vomiting, they're losing acid. So they're left with base. So metabolic alkalosis is what your bulimia nervosas are at risk of. Okay, so keep that in mind. So a couple more things. The calluses that your bulimias have, there's a name for them. They're called Russell's sign. Okay. And I always remember when I'm teaching to mention that because I remember a student come right after the test. I love talking to y'all after the test where she says, what's Russell's sign? I'm like, oh my goodness, you had a, bulimia question. She's like, yeah. I'm like, yeah, Russell's sign is the callus on the knuckle. So please remember that when you get that question. Okay. There isn't a pill for these disorders. Just like OCD, you're treating the underlying cause. There's no pill for this where you say take that. Now, a couple more things. Your anorexia, let's go back. Your anorexia nervosas, they're gonna try to trick you to make you think they gain weight, right? You weigh them every day, same scale, same clothing, same shoes, same, but they're gonna do things to show you they gain weight when they haven't. So they're the ones you need to watch them eat. You need to make a deal with them. You want them to keep a journal, all that, because they're also gonna want exercise privileges because they want to lose weight, right? They're already bony, but they want to lose weight, so they're gonna try and make a deal with you for you to let them exercise. So number one, weigh them every day, same scale, same clothing, check their pockets and all that to make sure they're not trying to look like they gain weight. But NCLEX, the best way for you to know that they've gained weight is when the women, anyway, is when they start to menstruate, right? They start to get their period. So that tells you they've gained enough body fat, okay? You're not gonna be able to fake that one, right? But yeah, they're the ones, make a deal with them. If you eat this much, then you get this much privilege, okay? All right, try this question. All right, throw me a couple of answers for that one. I know the last few I've been inserting it because of time. I wanted to practice as many questions as possible, but let's do this one. So let me reconnect so you can send me some answers. A nurse is caring for a client with anorexia nervosa who has nursing diagnosis of imbalanced nutrition, right? Obviously, less than body requirements related to dysfunctional eating patterns. So first of all, you don't want to read this question and not pay attention that it's anorexia nervosa and not bulimia, okay? So because sometimes, especially with the multiple choice, they'll throw answers there, that deals with bulimia, and then the question is anorexia, or vice versa. They give you a question on bulimia, and some of the answers would be for an anorexia. So be careful with that. Which intervention are supported for this client? So again, you've got to process the diagnosis. I see some of you throw me some answers here. Okay, so yeah, 1, 2, yep, 4 and 5, perfect. So yeah, small frequent meals. So you see how they have the opposite here. 3 substantial meals. So opposite, right? One is correct and one is wrong. Monitor the weight, right? Both of them, we want to do that. Allow the client to skip meal. No, we're not going to do that. The journal is great. Monitor them during meals. They're the ones who are going to go vomit. Now, if this was a bulimia, you don't need to watch the bulimias eat. You need to follow them to the bathroom, right? See why you need to pay attention to what disorder you're dealing with, okay? The nurse is conducting an in-service education session about the relationship between anxiety and bulimia. The nurse best described the relationship by saying when the client has bulimia, an increase in the anxiety level will generally result in, this is very easy, right? And them overeating, yes. They're gonna be binging. They're the ones who binge and purge. But let's go back. The nurse best described the relationship by saying when the client has bulimia nervosa, an increase in anxiety level. So this is questioning you about the anxiety part. So that's why it's that overeating. So now if we're talking about the disorder in general, after they eat, they do go purge. They're the ones who do that. They don't control what they eat. They have a problem. It's not an alcohol problem. So, but I like this question because, and I was going to go through it real quick, but the reason why I went back is because some of you may say binging and purging. The reason it's just overeating is because the question is just asking me about the anxiety part. So the anxiety causes them to overeat. Okay, nice question. All right, your autistic clients. So these are the children who they don't relate to others. So they tend to not be great communicators or socializers. You talk to them, they don't answer. Not many questions on here on this section, but they have ritualistic behaviors. They cannot deal with change. They do the head bang, the hair pulling out, but we don't stop them from doing it again unless it's self-destructive, right? They're the ones also, they need a ritualistic, they do the ritualistic behavior, we allow it, but they also need that structured, predictable, know what's gonna happen at 9 o'clock, 10 o'clock, 11 o'clock, right? That's them. Okay. Child abuse is another area. So with child abuse, don't forget, we're mandated by law. You have to keep that in mind, because if you sense child abuse and you don't report it, you could lose your license. Okay, so we take this very seriously, and don't forget, you're an advocate for both the young and the old, and those mentally incapable. Okay, so failure to act, what the definition in general, an act or failure to act, because a lot of time we think it's something somebody does. Sometimes if you're responsible for someone and you don't take care of your responsibility, right, that's a form. So an act or failure to act that causes physical, sexual, psychosocial, physiological harm to someone, okay? So don't always think it's something you do. So sometimes it's something you didn't do what you were supposed to do, okay? So I want to zone in intimate partner abuse, domestic violence, because there's a couple of questions with domestic violence. But here's where I want to stop and remind you of Maslow's hierarchy. I know you know about that. We've talked about it before. So don't forget, Maslow's hierarchy tells us physical needs are always priority. Eating, sleeping, homeostasis, air, right? All of that. So all of the physical needs need to always take priority. Let me give you an example. So you have a woman comes into the emergency room and she's been battered, right? So she has bruises all over her. What's the next thing for the nurse to do? You need to do some diagnostic tests, some CT, some x-ray, something to make sure she's not bleeding internally, especially in the question if they say she's pregnant, right? We want to take that fetal heart rate. We want to make sure the baby's okay, the woman's okay. So the physical needs are priority. Now, after all of that, right, we can talk about a plan. You know, especially if the person doesn't want to press charges. Remember, you can't make them. If they're awake, alert, oriented, you can't make them. All you can do is help them put a plan together, give them some support system number, like maybe women in distress type of thing, but you can't force them. Now, here's another type of question, and I'm going to get back to the intimate partner abuse. So with these type of questions, you as the nurse need to do something we call self-reflection, okay? So I don't know if I mentioned that in the past. Self-reflection is you, the nurse, need to know and assess yourself and make sure you can handle the client that's being given to you. So for example, if you have a history of being battered and you're being given a client who's been battered, can you handle that? So you have to do a self-reflection and make sure you can handle that before you take on that client and then you relapse, right? So keep those things in mind. So Maslow play a major role in these answering these questions, and I'm hoping I have time to practice a few with you. There's something that's crossing my mind. There's a defense mechanism that I didn't cover, I want to cover. It's called transference and countertransference. So sometimes the client thinks or sees you as or you remind them, okay, the nurse reminds them of somebody in their lives. That's called transference. So you walk into the patient's room and you remind them of their favorite aunt. That's transference, okay? Depending on the person you remind them of will gear their behavior, right? If it was a good relationship, they'll behave and take everything you give them. If it was not a positive relationship, then you might, not get the best client. Now, when the nurse or the healthcare provider does it, that's called countertransference. It is not appropriate. It is not professional. So we, the healthcare providers, cannot do countertransference. When we do it, so we walk into the client's room and they remind us of our favorite aunt. And then we treat them differently based on whom they remind us of. Okay, not appropriate. Okay, so when the client, the patient does it, it's called transference. When we do it, it's called countertransference. Okay, all right. I just was reminded of that. One more thing that I'm reminded of, there's a disorder called Munchausen syndrome. Munchausen syndrome is when the client or somebody, the caretaker, makes someone else sick to get attention. So sometimes you'll see Munchausen by proxy, right? The healthcare provider makes the child sick because they want attention. Munchausen syndrome. Okay. All right. Quite a few things came to my mind just right here. Intimate partner abuse. So with intimate partner abuse, there's a cycle. You need to remember that. Okay. The phase one is the honeymoon. Everything's beautiful. Everything is calm. I love you. And then tension builds. That's phase two, when the tension builds. And then the explosion, that's phase three. And then reconciliation. But the whole thing you need to remember for NCLEX is that it's a cycle. Okay, it starts over again, and then phase two, phase three, phase four, cycle. All right, so that's with intimate partner abuse. The honeymoon phase is the one they like to question you about. All right, you know your men dated. Now I want to remind you, whenever you're dealing with clients who have been abused, or even some of this other stuff we just talked about, crises, stress, all of that, don't forget, even when you're awake, alert oriented, research says we only retain 20% of what we hear, like literally. Isn't that crazy? So imagine somebody who's going through a crisis or some type of, situation like we're talking about, they're not going to retain what you're saying. So not only do you need to do that verbal, report and direction, but you also need to give it to them in writing. Okay, very important. They don't retain what you're saying verbally. All right, we got to talk about Baker Act for a moment. So there's 3 reasons you could be Baker Acted. You're a danger to yourself, you're a danger to others, or you cannot care for yourself, right? So once you're Baker Acted, you cannot leave. You retain every other right except the right to leave. Okay, so there's a whole 72-hour hold where you must be assessed and all of that. And if you change your mind, let's say you were self-admitted and you change your mind and the physician deems you to need to be Baker Acted, you'll have to go through the court process in order for you to be released. And that whole process is called writ of habeas corpus, okay? Or if whoever Baker Acted you really feel like you're a danger, they could do, the court could do what's called a Marchman's order, where they force you to get the help, right? So that's another thing you can do. All right. Restraint. So don't forget, restraint, you can never have a PRN standing order to restrain. That is a last measure. It is an emergency. If you're restraining the client, it automatically expires within 24 hours. The physician has about an hour to come sign that restraint. So let's say Mrs. Jones gets combative and she needs to be restrained. You're going to restrain her. And then the moment you're done, you're going to pick up the phone and get that verbal order. And then the next day, 24 hours later, exactly on that time, it expires. If you need to continue to restrain, then you need another order, okay? And don't forget, depending on the type of restraint you use, whether it be seclusion, physical restraint, chemical restraint, there's little rules and stuff you need to follow, especially with physical restraint, right? With physical restraint, let's say you're using a posy vest or something like that, you need that quick release tie, right? You need to make sure it's 2-finger breath loose. You need to make sure it's tied on the bed frame, not the side rail. So like all these little things you need to keep in mind when it comes to restraint. And there are a lot of rules concerning restraint for a reason. Okay, remember I always tell you, ask why, what's the why? So with the quick release tie, the reason we do a quick release tie and we don't do a nice, beautiful, tight bow is because if the client starts to vomit, we can quickly get them out of there and turn them to their side so they don't aspirate their vomit, right? So that's the reason for the quick release tie. We tie it on the bed frame and not the side rails, because side rails go down. And if you tie it on the side rails and you put the side rail down, you'll choke the client. That's why we always tie the vest restraints and these type of restraints on the bed frame. Now that makes sense, right? The finger breath loose is so we don't choke them, right? And we need to release them and have them do range of motion, go to the bathroom, all of that good stuff, right? We don't just tie up, drug up, lock up people and forget about them. Oh, so at the beginning, we mentioned Madame Peblo, right? The mother of psychiatric nursing. So, and we told you she came up with this therapy called milieu therapy. So milieu therapy deals with the environment, okay? Madame Peplo did her research and says that, okay, when clients are in a thriving environment where Maslow's being met, their physical needs are met, they feel safe, loving, caring, all of that stuff, they tend to thrive. And Madame Peplo is right. So there's questions on the therapeutic therapy, okay, that deals with the environment. Okay, it's an environment that's promoted to healing, that's a therapeutic environment. So keep that in mind. All right, we are done, and we are going to practice questions for the next 12 minutes. Let me see if you have questions first. Let me go back to, all right, here's one. The nurse overhears the supervisor reprimand the head nurse for not discussing feelings with a patient. Shortly after, a patient asks the head nurse for an extra blanket, and the head nurse angrily responds, "Get it yourself." The nurse recognizes the head nurse is displaying which of the following defense mechanisms? Just throw responses at me as we do these questions so I can, like, flow with it. That way we can get as much question done as possible before we get thrown out. Because you know how this works. Like, it just 4 hours, boom, we're done. It doesn't play around. All right, so I'm gonna try and give you like 30 seconds because I know there's a 30-second delay from when I'm speaking and when I can see it on this screen with your responses. So I give you about 30 seconds and then we go over the answer. Throw me some answers. And the moment I see the first answer, I'm going to move forward. Yes. No. Yes. Displacement. I was like, yes. So, yes. It's displacement. My eyes messing with me. It's displacement. She's not angry at the client. No, she's angry at the nurse that reprimands her. The head nurse. This is the head nurse? Supervisor that reprimands her. So that's displacement. Okay, so that's one of the ways that they would phrase these questions. We just learned that material. A couple experienced the loss of a 7-month-old fetus. In planning for discharge, what should the nurse emphasize? So now there's been a loss. You need to see some venting. Okay, that's why I took my time and went over that word. We need to see some venting. So what answer here shows me that there's some venting? 15 seconds. Yes, discuss feelings. That's the only thing here that tells us they're venting. The others do not, and that is as simple as that question is. Only A is venting, okay? A nurse and client are talking about the client's progress towards understanding his behavior under stress, which is typical. This is typical of which phase of the therapeutic relationship, because remember, we have an orientation, a working, and a discharge or termination phase. So if they're talking about the client's progress towards understanding his behavior, are they in the orientation, working, or termination? So this is working phase, okay? Yeah, they're discussing the problem. Easy. Here's another one. A client states, "People think I'm no good." You know what I mean? No, but let's see which of these responses would be most therapeutic, okay? So the word most there tells you there are other answers there that may be therapeutic, but one of them is the most therapeutic. Well, people often take their own feelings of inadequacy out on others. Isn't that an opinion? That's an opinion. It can't be the answer. I think you're good. Don't even read the rest of that. And we tell you to read everything. But if half of it is wrong, the whole thing is wrong. I think that's an opinion. Get rid of it. I'm not sure what you mean. That's true. Tell me a bit more. Open-ended. That's the most therapeutic thing here to say. D would set them backwards. Let's discuss this to see the reason. You admitting that. Yeah, D would cause them to go backwards. The answer is C. I'm not sure what you mean. Tell me a bit more. You're not, you're truthful, you're honest, and you have an open-ended question. Beautiful. A client tells the nurse, I have something very important to tell you if you promise not to tell. The best response by the nurse is, I cannot make such a promise. You can't. Because let's say the promise is, I have a bomb in the cafeteria, I'm gonna blow everybody up, right? You can't keep that secret. And remember, you have a therapeutic relationship with, it's a client-nurse relationship. You can't keep secrets. Friends keep secrets. You can't be friends with your clients or date your clients and stuff like that. My goodness. I read an article years ago where it said that the jailmates, like the nurses date the jailmates, like those who work in the prisons. Often I'm thinking, what on earth? Like, but apparently there's like a high rate of that happening. Weird. I don't get that. But you're not your client's friends. You can't keep secrets. Friends keep secrets. You can't even deal with them outside of your institution. Okay? A depressed client is in an assisted living facility, tells the nurse that life isn't worth living anymore. What is the best response? Remember, no shade of gray. Okay? Come on, it's not that bad. Yes, it is. Have you thought about hurting yourself? That's it. Go there, go there, go there. See, did you tell your family? You're passing the buck. And Clex doesn't question you to see that you can pass it on somebody else. Those answers are never correct. Okay? Think of the many positive things in life. All right. The answer is B. Oh, all right. Some of these answers are funny. The primary nurse on the locked psychiatric unit receives report from student nurses in the assigned patients, on the assigned patients. After receiving the report, which of the following patients should the nurse see first? Okay, so this is a who do you see first. You have a Minneapolis client diagnosed with bipolar disease threatening to sue the primary nurse. This is a Maslow thing. Suing me will not kill me. Get rid of it. A patient diagnosed with depression stating that things are better and that he will be leaving soon. That's your problem. They're diagnosed with depression and all of a sudden everything is better. Remember we talked about that burst of energy? Now they have the energy to do it. Put a one-to-one sitter with that client. Let's look at the others. A patient experiencing delusion states that he will kill her husband once she is discharged. She's still under your care. Now, if you discharge her, that would be a problem. Can you at least warn the husband, right? But number two takes priority over number three because they're still under your supervision. And if they escape out of your facility, definitely warn the husband. A client diagnosed with schizophrenia